Hello, everyone, and welcome to another episode of Wellness at the Speed of Light podcast. I'm your host, Dr. Stefano Sinicropi, and I am just really excited about this conversation with Dr. Kerri Anthony, who is an amazing board certified OBGYN who is doing incredible things in perimenopause and menopause and everything else. Women's health, and is out there doing a whole amazing telehealth program, which we'll talk about, and really helping guide women through a very difficult, transition in their lives. And there are so many women that just can feel completely lost and they don't know where to go. And I hear this now going down the rabbit hole of integrative health. I hear this more and more. And so I'm trying to educate myself so at least I can send people, in the right direction and at least help. And also a lot of the medications we give people can affect all these other symptoms. So it's very important for us that are treating things like depression, anxiety, or whatever it is, to really understand how perimenopause and menopause factors in. So on that note, we're gonna do a deep dive today into everything perimenopause and menopause. And as I was telling Dr. Anthony before the show, the reason I really wanted her on is because she's an amazing communicator. And I started using her short clips to educate myself on this stuff. So I said, well, why don't we just have her on the program? That would make a lot more sense because then I can actually have this conversation. So on that note, thanks for joining us today.
Thank you so much. Thanks for having me. I am thrilled to be here and kind of do a deep dive really into all things perimenopause and menopause. Yep.
Exciting, exciting. I never thought, like if you had asked me 5 years ago, if somebody said to me, hey, one day you're going to be doing a show on perimenopause, I would have just started laughing. I'm like, what?
Exactly.
What are you talking about? But no, it's really important looking at people as a whole, and women's issues
Absolutely.
are so much different than men's. And when we do a one size fits all, even within like women, everyone's different, right? I know you
Correct.
talk on your shorts about how it's not a one size fits all strategy. It's
Mm-mm.
not like you have you do this, then this, then this
No.
for everybody. No, you have to feel it out and know. So let's start. This is real important. Okay. So for the women that are watching this right now, I know you're frustrated. There's a high percentage of women that report. There's all these articles. This isn't just me saying it because it's like
Correct.
anecdotal. There,
Yeah.
this is well studied. How frustrated women are when they can't get answers. They're
Yes.
having all these symptoms, and they're told, I always say, oh, they go get a hobby. Oh,
Yes.
you're just depressed. Here's an SSRI, which
Hmm.
obviously may make them even worse
Yes.
with their symptoms, or just completely blown off. It's just like you're fine. Your
Deal with
labs
it.
are good. Like deal with it.
Yep.
And when I say labs, I mean like their blood counts are good. Okay, good. You don't have cancer. Good. That's great. But I don't feel good still. So what do we do? So in 2025,
Hmm.
my first question is, why are we still having this
Oh,
conversation on why like the people are not being educated on this
yeah.
particular topic? There's a lot of women out there, right? And this is a transition that happens to everyone. So how do we
Yes.
not know about it?
Well, I think the biggest thing is education. So again, I'm a board certified OBGYN, meaning I did medical school and then the additional training of residency in obstetrics and gynecology. And we did not get the education. Now I'm 20 years out, so we can kind of throw that in there, but we really did not get education specifically about perimenopause. So when we were treating in residency, we only treated patients once they'd gone 12 months without a period, which is the definition of
Mhm.
menopause. And we only offered menopause treatment. The gold standard is hormone therapy. But we only offered that once a patient had come in and had gone 12 months without a period. There was never any education about perimenopause, which is the 2 to maybe 10-year time frame before menopause. Average age of menopause in the US is 51. Normal menopause can happen anywhere from 40 to 58. So
Wow.
perimenopause, if we're looking at it, could if menopause can happen at 40, then you could start perimenopausal symptoms at 38, at 30, at 35, at 36, and the symptoms are all over the place. It's not just hot flashes and night sweats. So the thing that we learn is once you're menopausal, you'll have hot flashes and night sweats. Nobody talked about mood changes. Nobody talked about libido changes. No one talked about joint pain and skin changes and hair thinning or hair loss. That part was never part of the core education. And it's only now in 2025, I think, because many of us as OBGYNs and urologists and females in that space are experiencing perimenopause ourselves. And it really kind of allowed us to shine the light on, oh my gosh. I mean, for me, my own journey, I had no idea that that's where I was.
Mm,
I just started having just, changes in my emotions and control of those emotions, which I'm usually, my whole mantra was, you stone face, no matter what. And I realized, okay, at 48, this could be actually perimenopause. And it was my great friend and colleague who I had practiced with for several years who said, I think you need to start hormone therapy. I was there for a totally different reason. And I thought, well, no, I'm not having hot flashes or night sweats, right? So in my mind, as a board certified OBGYN, I thought the same thing. Well, I haven't started having hot flashes and night sweats, so maybe not. But once I started hormone therapy and those symptoms resolved, I
hmm
realized, oh, we've been doing a disservice. We have not been offering any of this. And then I thought back in 20 years of practice, how many patients who might have been 36 or 37 who just started to have some symptoms. I too was one of the doctors who said, well, this is normal. Like you should just be fine. Let's start an anti-anxiety antidepressant. That
hmm
was me. And so now that I'm in the journey and I'm like, oh, no, no, no. We need hormone therapy because really if we think about the anti-anxiety antidepressants, let's just say we start that. We just
hmm
start you on that. If you're already complaining of decreased libido, if you're already complaining about weight gain, and we put you specifically, our first choice is, as you mentioned, an SSRI. So it's Zoloft or it's Lexapro.
hmm
It's one of those that already comes with a side effect that may affect libido. It may
hmm
affect weight. It may affect the ability to orgasm. And you're already complaining, and those are part of your complaints. And then we throw that medicine and then you think, well, something has to be wrong with me, right? I'm broken. Something is wrong because they told me I needed this and this isn't working and I'm feeling worse. And it really is, it's the education. We just didn't get the education. So now you've got, physicians like myself who are, we want to educate. I want everyone to know the options. I want you to know the symptoms and I want you to know that you're not alone in the journey.
Yeah, I mean, I think that's a great answer, and thanks for being frank. I do, I've made so many posts where I talk about how I was blowing people off for stuff that
Mhm.
that I know about, and again, just different stuff. Forget about the like this stuff that because
Yeah.
I've heard these complaints from women forever because they get
Yeah.
to trust you, and then they just tell you all this stuff. And I'm just like, what do you want? Like, what am I
I don't
gonna,
know what to do
like,
here.
what am I? Luckily, I have color in my skin, so they're not seeing me, like turning red early
Yeah.
on when they're giving me every piece of information about their life that I wasn't,
Yes.
asking about. But for stuff, even my own specialty, we didn't know like all this. I do so much in the world of biohacking now with light
Yes.
therapies and laser therapy and stem cells, all the stuff. People would ask me about that all the time beforehand, especially like the regenerative medicine. And I'm like, oh
Yes.
my God, who's taking your money? Like this is ridiculous.
Exactly.
And now I'm
Yes.
doing, now I'm doing TED Talks on the stuff. It's just it's crazy how
Hmm.
we change, and I think that that's real important. Think about it.
Yes.
You're a board certified OBGYN with a great training. You've
Right.
treated patients for a long time,
Yes.
and you yourself couldn't recognize the symptoms
Nope.
in your own self because that sometimes it's interesting how many of these like these pockets are missing in our medical school training and
Yes.
residency. It's like missing. But I think with time and education and
Yes.
people like you and me, where we're like 20, plus years out, we're starting to just say, oh my God, I'm sorry. I, I,
Yeah.
I missed it.
Yes.
And let's go. All right. So let's go back. So
Yeah.
one a recent post I did, which I just start thinking about stuff and I just have to get it out to the world. But I talked about the fact that there are a lot of influencers out here and they don't maybe not have the expertise, or they have some kind of financial motive, right? They're
Yes.
trying to sell some product or something like that, but they have a lot more more
Mhm.
likes than we
Absolutely.
do, and they're just more well known. And so people go that direction. I don't have a problem with them if they're trying to help people and put things on the radar. I think that that's wonderful. But the
Yes.
point of kind of what I was trying to get at is, as physicians, it's really important for us to become the influencers for our patients. And I think
Yes.
that you're doing that now. In this world of like perimenopausal symptoms and this and that, you've got people like, like Oprah, ringing the
Yes.
bell, and
Yes.
Gwyneth Paltrow and stuff like that. So, you know what? Power to them.
Yes.
And it's a little sad that you have to have celebrities as they're going through it and they're getting blown off and they're worth, like
Yes.
Oprah's worth like a
Yes.
billion, who knows how many billion. I don't think Gwyneth Paltrow is quite worth a billion,
Yes.
but I don't think she's, she's not
Yes.
really, no coupons at the supermarket. We'll
Yes.
put it that way. So,
Yes.
but by the way, but it's a little frustrating, but it's also, we have to support that because they're
Hmm.
helping us. So what do you think about this concept? Because this is really what you're trying to do. You're trying to be really the influencer to your patients. Why? You have the expertise, you have the background,
Yes.
you made the commitment.
Yes. Well, I think really one is because I have the training. So when we think about
Right.
looking at celebrities, they don't have the training. They haven't gone through medical school or residency or even the additional training that we get to do to be menopause certified by the Menopause organization. But I think walking through it as well, Oprah's a little bit older, so she's kind of on the other side of that
Right.
menopausal journey. Of course, sharing and being open about it. But I think, for those of us, including myself, like my biggest motivation was my own experience.
Of course.
And again, when I think about the patients who might have been told you can take an anti-anxiety antidepressant or take a birth control pill, they're still being told that right now.
Mm.
So the patients that I see have gone to a primary care and some have gone to gynecologists and been told you're too young, it's too
Hmm.
early, come back when you've gone 12 months without a period. And then they see social media, they see Oprah, they see Drew Barrymore and
Yep.
all,
Yep.
and even Halle Berry, who was dismissed, when she had symptoms. And they're like, okay, well, if these celebrities are saying that I can be treated, why is my doc telling me that I don't need treatment? Why is my doc telling me this is a normal process? Some of the things that I have heard, I mean, are just use more lube,
Just
go ahead and be more sexually active, even though it's painful. The more you use it, the better it'll be. Like, I mean, these are the things that I get when I'm seeing a patient. These are the things that they're being told and never offered the gold standard, which is hormone therapy. And I
course.
think a lot of women are afraid because of the Women's Health Initiative study that was, that came out way in the early
Mhm.
2000s, and black box warnings placed on hormone therapy, and women stopped taking hormone therapy. That's when I was actually in residency training,
Mhm.
and we saw the women, they saw it on the news and they said, oh my gosh, I can't take hormone therapy. But we've got 20 plus years of research after the WHI, and we know that really a lot of the things that they did then we aren't doing now. We don't offer the same hormone therapy. We
Mhm.
offer bioidentical hormones. They use synthetic hormones. We use transdermal hormones. They use oral estrogen. So there's so many different things that we're using now that are different. And we've got research that shows some of those numbers that they gave us we really don't trust. But again, if you're a primary care physician or even a gynecologist who just has not looked at that literature since it came out in the early
Mhm.
2000s, you may be telling patients they shouldn't take hormone therapy. These are the risks, and the risk outweigh the benefit when really it's the opposite. And so I think when you have those celebrities who have access, right? They've
Yes.
got
Yes.
access to those physicians who have done the extra research, and they can pull those physicians in and then have those
Mhm.
physicians speak. I think, uh, they opened the door, but they just have better access where we have our patients in the states that I serve who don't have access like that. They don't have doctors who have that knowledge. And so I go to social media so you can kind of
Mhm.
watch and get the education so you can take that education that I'm giving and go anywhere and say, well, this is actually what the studies show. And this is actually what the literature says. And you can even print it out and take it in to be your own advocate. So the goal for me is to allow patients to be their advocate in this journey if they don't have me as their physician.
And I think that, I mean, that's brilliantly said. And I think it's important for people to understand a lot of that same stuff really happened. It was around that time with men's hormone replacement,
Mhm.
therapy, with complete like stuff that's so debunked so long ago.
Yes.
Right. But there's still a group of men, but not just a group of men, because, even at our clinic, our integrative health clinic, we do a lot of hormone replacement therapy. And
Mhm.
I'm just being honest. There are urologists that are still telling these men that have testosterone levels of 112 that
That they
they
can't.
don't well, maybe you don't need it, there's risks, there's this or that, and
Yeah.
then that's like an outlier. The big ones are the ones, the men are that are like, they're like in that 350 range,
Mhm.
something like that, and they're told something, but then you know what, you boost them to 750 and it's a different person
And they feel
sitting in front
normal.
of you. It's insane. And of course, there's other things. I mean, people
Of
have
course.
other problems. It's not just you give them
Yes.
testosterone and it changes their, their whole life. As long as you educate them and explain to them that this is a lifelong,
Yes. Yes.
journey and this and that, and explain to them that, yeah, whatever, yeah, we work them up, we make sure, their PSAs are normal and they don't have stuff. And if
Yes.
they do have just BPH, it could make it worse. You just work with their urologist and you make sure that everything, is going, but there's
Yeah.
really, it doesn't cause cancer. That's
Correct.
important, and I think that's very similar
And
in female
yes.
literature. But
Yes.
people are afraid, and then they suffer, and they suffer for long periods of time. And so that was my next question. So you just kind, it's like, okay, we're 2025.
Mm-hmm.
People are like, why are
Yes.
you always so negative? Because because I get upset about stuff. It doesn't. It's ridiculous it's so frustrating that you need a spine surgeon here trying to educate
Yes.
people on like even male hormone replacement therapy. I was like, this is not what I signed up. I love it because it's part of the big package. I like,
It is.
holistic treatments and stuff
Yes.
like that. But it's just interesting. Why? Same question that we started with.
Yeah.
Why is there still this misinformation on hormone replacement therapy and such a fear, to begin it,
Yes.
in the first place when the
Yes.
studies clearly show a dramatic improvement in so many
In
people?
quality of life, yes. Well, I think again that when you think back to the early 2000s when it broke the news. So
Yeah.
when that study was discontinued because women had strokes and heart attacks and blood clots in their legs and lungs, so DVTs and PEs,
Hmm.
and there were women diagnosed with breast cancer. But let's just go line by line through that. Our risk of breast cancer just being born a woman is 1 in 8. Okay, so that's all we have that risk. We cannot get rid of it. That risk is going to be with us for life. And those of us who are blessed to make it past menopause, if we compare our premenopausal years to our postmenopausal years, the likelihood of that diagnosis, if the diagnosis is going to happen to us, it's more likely to happen postmenopausally. So if we take a group of women who are 50 to 79 and we enroll them in a study, we must expect if there's more than 8 women, there's 160,000. We're going to see women diagnosed with breast cancer if we follow them for years. They didn't even have to be in the study. We could have just randomly picked a group of 10 women and we would see at least one if we followed them over years,
Hmm.
especially in the postmenopausal years, we would see someone in that group diagnosed with cancer. Now, when we look at the study, we used oral estrogen and oral progesterone, and they were synthetic. Now we use more bioidentical. So
Hmm.
we prefer to use the bioidentical versions, which are FDA approved and covered by insurance. So you don't have to go out and get a specialty compounded hormone to stay in the bioidentical range of taking. Like you can
Hmm.
still get it, the FDA approved, that's covered by insurance, or you can get a like it's either or. But I think, and we'll come back to that,
Hmm.
that kind of the compounding pharmacy option really grew after the WHI because women were
Yes.
afraid. But we'll come back to that. But again, if we're looking at women and they're postmenopausal and we've got more than 8 in the study, we're going to see breast cancer. But really, we've got studies after the Women's Health Initiative out of Denmark, out of France, where they actually looked at the progesterone. And so our concern is more that it was the type of progesterone in that study, which we don't use. We use micronized progesterone,
Mhm.
which is identical to the one that we produce anyway. Again, this one was a synthetic. So we have research that came after the WHI that really said, okay, it may have been the type of progesterone, but it may have also been, when you look at that study, it was only the group of women who took estrogen and progesterone who had a slightly higher risk of developing breast cancer than the placebo group. And it was about 1 in 1,000. That is a tiny, tiny number. Again, ours is 1 in 8 just being a woman, right?
Yep.
So we did not see a causation there. So we didn't see that. Okay, you took this and it caused it. Were we going to see that anyway? And interestingly enough, the group of women who took estrogen
Mm.
only, so if you've had a hysterectomy and you take hormone therapy, you don't require progesterone. Progesterone is required for women who still have a uterus
Mhm.
because estrogen thickens the lining of the uterus and progesterone helps to protect it and keep it thin. So in that study, the women in the placebo group had higher numbers of women diagnosed with breast cancer than the women who took estrogen only.
Mhm.
So, estrogen only, that group had the lowest number of women diagnosed with breast cancer. But we don't say, okay, take estrogen and it's going to decrease your risk for breast cancer. We can't say that either. That study didn't allow us to say that.
Correct.
But
Yep.
again, it doesn't allow us to say that there's a causation because there was a 1 in 1,000 increase. That number was so tiny. But then we look and say, were those numbers because in the estrogen only group, many of those women had also had their ovaries removed? Did they already have a lower risk because they weren't producing estrogen anyway for several years? Because when you had a hysterectomy back in the 90s and early 2000s, most of the time we took the ovaries out. Now, because we know there's a cardiovascular protection
Hmm.
in keeping ovaries, we don't do that anymore. But in that group, there's so many areas for us to say, are those numbers really absolutely realistic? Because were we protected in the group of women who took estrogen only? Was it the progesterone? And even if it was 1 in 1,000. 1 in 1,000. That is a tiny, tiny number again, because our risk just being women is 1 in 8. Additionally, when we look at that study, they enrolled women who were 50 to 79.
Hmm.
So some women in that group were 79 years old being given hormone therapy for the very first times in their life. And what we found was that women had strokes and heart attacks. Estrogen is a hormone that can increase the risk of forming blood clots. And if we look at a 79-year-old woman and a 50-year-old woman, and we just taking no medicine, we just look at the blood vessels in their body, we know that as we get older, our
Hmm.
vessels become more narrow. We have plaque formation, even if we are not, patients with high cholesterol who need to be on statins. Just aging alone, we will see a change
Hmm.
in those vessels. So if we give a patient a medicine that may increase that risk for clotting, but we compare the 79-year-old vessels to the 50-year-old vessels, if a clot forms, the 79-year-old is probably going to have a more narrow vessel where that blood flow can be stopped and we can decrease blood flow to the brain, which may increase the risk for stroke, or in the heart, increase that risk for a heart attack. So if we just look at age and look at the women who were 50 to 60 in that study and we followed them out for 20 years, that's done. We've got the literature, we've got the numbers. The group of women who started hormone therapy who were within 10 years of menopause in that range from 50 to less than 60, those women at 20 years had lower rates of cardiovascular events than the women in the placebo group. So the women who took no hormone therapy, those women that we followed out for 20 years, they had higher rates of stroke and heart attack than the women that we started on hormone therapy. That literature is out there. It's there. We've talked about it, but there are still physicians who are unaware of that information. And so they still make recommendations based on the news media release that happened in 2000, 2001, 2002. That's what they're working on. And so we're we're telling women that they don't need hormone therapy, that they should maybe take vitamins or supplements, and we are missing the benefit of giving them some cardiovascular protection because we go back to what happened when that study was discontinued and that media release happened. And that's just not right. Like, I mean, we there's a benefit here. There's a bone benefit, there's a heart benefit, there's a quality of life benefit. And if you see patients like I do and they start hormone therapy and they come back and say, I now feel normal again,
Hmm.
you would not be able to deny them the option of making the decision, making the informed choice, and giving them all of that information to allow them to change their lives.
Yeah, I mean that was great. That was great. I mean, you broke it down exactly. That is what it is. I mean, it's very and people, a lot of times my patients come in and they want to talk about studies and they want to do all this stuff.
Yes.
Especially now with social media and
Yes.
Google and the combination of it, and now AI. They come in with
Oh,
their
yes.
list because chat. Here's what
Yes.
Chat
It's like,
GPT
yes,
says.
it is.
Let's discuss it, doctor. I'm like, great. We're going to be here all day. But anyway. The truth is, a lot of times I just tell them, and you hit it on when you said before, people are not trained. We have spent our entire lives, right? I mean, how many thousands of articles have you
Oh
read
my
through, right?
goodness.
So we know how to comb through stuff.
Yes.
And after all this and all I mean, I just have a stack right next to me of all these articles that,
Same.
I want to get read like this week. But the interesting thing is, like people like, I was like, I'm going to just boils down to one thing. It's complicated. It's complicated. There's
Yeah.
a million different factors. You cannot just pull out
One thing
one thing what you want, and that's what the media tends to do. And then
they
it gets
do.
sensationalized and it turns into this crazy, oh my God, they're killing people and we got to
Hmm.
stop it and black box warnings and all, this other stuff. It's no different to me that, one of the like my pet peeves, and I talk about it constantly, is when we are trying to treat complicated diseases, like, for example, depression or,
Yes.
whatever it is, with a single molecule and not look at the root causes. It's
Hmm.
complicated. So even though, yes, we can treat them with some very expensive medication that has a ton of side effects and show that we're dropping whatever marker we're looking for,
Yeah.
then we're not
Yes.
taking into account the fact that yes, the patient might have less of these symptoms, but their quality of life might be eventually even worse because
Yes.
they have to deal with all these other symptoms from that drug. So we have to take a very holistic, approach to it. And you obviously do that. That's what you do.
Yes.
I mean, you're really taking a good, but we have to dive into the literature. And when we're wrong, we have to, not just wrong. I mean, they try their best, these studies, right? There's a
Yes.
women's health initiative. They tried to figure something out. But when the studies, things are true until they're not.
Yes.
And so when they're not true, we
You have to
can't
come back.
we
Yes.
cannot keep living in that world. Another, example to me, like in my world, is this whole thing with the stem cells. I mean, people are still claiming like stem cells are like these embryonic cells. Like they're not even doing that stuff anymore because it doesn't
Yeah.
work. Because when you put embryonic stem cells in people, they turn into teratomas. They're tumors. That's not even what's being done. The Catholic
Yes.
Church and the Baptist Church both, like, they support and fund autologous stem
Mm.
cell research. It doesn't make any sense. But anyway, we're just
Yeah.
living in a different world. Before we get, because I want to really dive into
Oh
perimenopause and
yeah.
all the changes. But before we get there, one quick thing you had mentioned, because for the audience, and because again we talked about, like, a lot of the people, they don't understand, like, they're on this. You threw out hormones, right? You threw out
Yes.
estrogen and
Yes.
the
Yes.
progesterone, all this other,
Yes.
and then obviously there's the testosterone,
Yes. Yes.
aspect of it as well. Can you talk about, like, when you're seeing somebody and making a recommendation, or you're trying to put together a plan? And this is what I'm finding the more and more I go down this path, because now I know a lot of providers that are doing hormone replacement therapy in
Hmm.
women. Some are very obsessed, like, it's everything's testosterone. Oh my God, it's your testosterone. We're going to fix you. But I think that a much better, like, strategy is to, like, look at the combinations of
Of
all the
everything.
different hormones and see what's causing what, and see what the pituitary is doing, and hypothalamus, and you got to look at the entire axis and figure out, when it's you're inputting something, what's the output. And I feel like even those that are doing some hormone replacement therapy, sometimes their focus is very narrow and other things are going out of way. Like, what's your thought on that? I'm just trying to wrap my mind around why there's different approaches to this hormonal treatment, especially in the younger, women, the people
Yes.
that are in perimenopause.
Yes. So I think there definitely are different schools of thought on treatment. And I think the key, so we'll kind of go to the basics,
Yes,
the
yes.
the basic hormones, the two major hormones that the ovaries produce are estrogen
Mm,
and progesterone. And we do produce low levels of testosterone as well. But the two that kind of run our menstrual cycle
yes.
are estrogen and progesterone. And once we are menopausal, so once, we've gone 12 months without a period, difficult to know if you've had a hysterectomy. So we've got to do some other things to kind of figure that out. Or if using hormonal birth control or an IUD that kind of keeps you from
Mm,
having regular periods. But once we're menopausal, we are no longer producing estrogen and progesterone. So the ovaries have stopped their job, so that it's complete. We are no longer reproducing, and so they're not producing
mm,
those hormones anymore. But in perimenopause, the the issue in perimenopause, which is why it's just so it's so racked with different symptoms, is every day the hormones are just kind of doing whatever they want to do. So you may have the normal rise, one 28-day cycle, you may have the normal rise of estrogen and progesterone throughout the month. They peak, and if no egg is fertilized, they'll drop, and then we'll shed and have a menstrual cycle. That could be 1 month in perimenopause. The next month, the hormone levels, your estrogen could be higher than it's ever been in your life. It could be, if you've
Mm,
ever had a pregnancy, it could be at the point almost of what it was when you had a pregnancy.
mm,
And then within 24 hours or 36 hours, the estrogen level then drops down to almost zero. And what's happening is we're not ovulating every single month. And so those signals are not going to the brain. The brain is deciding, okay, we didn't have enough estrogen here. We didn't ovulate. Let
mm,
me send a signal back to the ovaries to tell the ovaries they've got to work harder. They've got to make more estrogen. And so because we're not ovulating, then the brain is trying to figure this out and sending the signal to the ovary. So then we make more estrogen.
mm,
So it's like a roller coaster ride. It could happen over the course of 3 or 4 days where your estrogen, which usually, if your estrogen levels are normal, you feel pretty good. They drop, you're emotional. You
mhm,
might have hot flashes or night sweats. You might just have rage. There's so many different things that happen, and it's because we're going on this hormonal roller coaster ride in
mhm,
perimenopause. And it's difficult to determine if you're perimenopause if you just check estrogen and progesterone because
mm,
again the levels could be normal. So when we're looking at perimenopause, it's really important to listen. It's really important for a physician to listen to the symptoms. And what will happen sometimes is if the patient says, I'm still having a period every single month, oh, well, then you're not in perimenopause. Can't be. You can't be because you're having period. That's not true. Just because
true.
you're still having periods every month, that doesn't mean your estrogen level wasn't high and low and high and low for 15 days out of the month that month. And so you really have to listen to symptoms because if we check labs, unless we check labs every single day for 30 days, which
Mm,
we're not going to do and insurance won't cover, um, but we can check the labs and they can be normal. And so this is where when physicians are listening to 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 my videos or anything, that key. The
yes.
hormone levels can be normal in perimenopause. And so if you call your patient and say, your levels are normal, you're great, nothing's wrong. And when she picked up the phone to receive that call, she's drenched in sweat because she's having a hot flash, or she just cried because one of the kids left an empty carton of milk in the refrigerator. Like she does not understand hormones are normal. She doesn't understand that because what she feels is that there's something wrong with her. And so if patients are in the age range of perimenopause, which really could happen anytime after 30, if their cycles were going to stop at 40, remember, because perimenopause could be
Mm,
2 years or 10 years or even just 6 months before, well, not 6 months because you got to go 12 months without a period to diagnose menopause, but all those symptoms can happen in our 30s. So if we meet the age, so if we're in the age range, we can do lab work to make sure, like you mentioned, looking at the pituitary. So looking at the hormones that are made in the brain, like the FSH and the LH, to
mm,
make sure we're not having symptoms because there's something else going
mm.
on, because there's a hormone secreting tumor there or in the ovaries or in the adrenal gland. So we usually will do a basic workup with all the labs. But what I say is expect that estrogen and progesterone may be normal. Testosterone may still be normal or low normal because ours is usually
Mm,
low anyway. Those may be normal, but if we ruled out that we don't think symptoms are coming from an abnormal thyroid, right? Because you can
mhm,
have
mm.
hypo or
Yes.
hyperthyroidism, which can mimic some of those symptoms. So there's basic labs that we want to have, but we have to understand that if you look at those estrogen and progesterone levels and call a patient and say they're normal, nothing's wrong with you, you're not helping. You're not helping. If they're
Not
having
helping.
symptoms, you're not helping at all.
Yeah.
And then they think then it's a mental illness. And I cannot tell you how many patients come and say, I was told that I have severe depression. I was
Hmm.
told I have severe anxiety. I'm in therapy. I'm seeing a psychiatrist. I'm doing all the things, but I still feel the same way I felt when I first went to my PCP and said I'm having these symptoms. And so we want to rule out all the things. We want to make sure that blood count is normal and that the thyroid is normal and that, we don't see any other abnormalities there. But then we can offer treatment even if hormone levels are normal. You can still give hormone therapy if hormone levels are normal. And I think that's the key. And patients need to understand that they are still candidates even if their hormone levels if they're told the levels are normal.
I mean, that's absolutely crystal clear. I think that is a point that needs to be just kind of shouted
Yeah,
off the whatever off the room. You might need Oprah to say it so that people
exactly.
understand that
Yeah.
we like I said, we need to be the influencers.
Mm-hmm.
For it's interesting. One of my one of the things that I've really enjoyed getting into in the whole integrative space, the integrative health space, is just general brain health. And
Mhm.
so, I did a bunch of reading on perimenopause and what happens to those estrogen receptors that lose their sensitivity, like especially like in the
Mhm.
hippocampus and
Yes.
hypothalamus. So I think that that's a big reason why, right? They look like, I mean, yes, they have symptoms of anxiety and depression, but
Yes.
it's a different variety of anxiety and depression. Then the other thing, and we can talk about, because I want to get your thoughts
Mhm.
on kind of the estrogen receptors in the brain
Yeah.
and things like that. But the other thing that's real interesting is this, looking at brain scans in these women and how they do get hypoperfusion,
Yes.
especially in the frontal cortex, almost like we
Like a
see
dementia. Yes.
exactly
Yes. Yes.
exactly like a dementia.
Yes.
And so this really got me thinking as I was going down this path, because we do a lot of light treatment to the brain because it increases the blood flow to the frontal lobe. We do it on a lot of elderly patients that have
Mm.
it, and we've worked with like the guys at Harvard and stuff like that for protocols. And it's interesting because now we're starting to do it with some of these women that have all these symptoms, and we're
Wow.
seeing benefit. It's interesting. We're seeing benefit. Now it's anecdotal, and obviously we need to
Yes.
get, these bigger studies done.
Studies. Yeah.
And anything that's not tied to big pharma, it's hard to get, how much
Of
studies
course.
cost. So
Yeah.
that's why
Yeah.
even like places like Harvard, they have trouble getting these studies funded because it's not tied to
Hmm.
a huge source but anyway, can you talk about like the
Yeah.
the the receptor center? Because I know then, right, it normalizes when they go into full menopause, but in that whole
Yes.
period, if your
When you're, because
receptors are off, right?
exactly. So
Yeah,
there's receptors in the brain, there's receptors in the genitalia, there's
yeah,
receptors, of course, in other parts of the body. But the problem is when we're not getting that cyclic estrogen
yes,
that we're used to, that's going to rise and peak, then those areas of the brain are not getting perfused, and we start to feel cognitive
yes,
symptoms. So there's brain fog, there's decreased ability to concentrate. So just even for just personal experience, being in meetings and the word is there, but I just can't get that word out of my mouth. And you know, when that started happening, which again I did not I did not correlate to this perimenopausal period, but once I started hormone therapy, I noticed that. So, of course, I told no one that I felt like I'm having to search for words. I can't, I'm not remembering as well. And I have a photographic memory. I can remember if I write a note, I can see it. Things started changing for me there before I started hormone therapy. And what I noticed was the improvement after being on it.
of
And
course.
that took probably about 2 to 3 months. But I said, oh my gosh, I was worried that there was something else going on for me. And that has disappeared because now I have a constant source of estrogen that's feeding those receptors. But I will, I will say, I have had patients come in, and this is just one great example. Um, 70 years old. This is me, fresh out of training. Again, I could look back and say, wow, I wish I could send letters to some of these patients that I remember, not offering hormone therapy. But 70-year-old patient comes in and she's a new patient on hormone therapy. And I say, oh, you're 70 years old. We've got to stop you. Your risk for heart attack now and stroke has increased because you're older than 65 and you're still taking hormone therapy. And she says, oh my gosh, nobody ever told me. Absolutely, I'll stop. So
Mm.
I see her first visit. We get her off of her estrogen. And within less than 2 months, she's back in the office. She's sitting in the room. And I'm like, what is she? And it says follow-up hormones. Well, we stopped your hormones. What
Res-
if? So I go in and she said, give me a piece of paper. I'm like, give you a piece of paper for what? She's like, tell me whatever I need to sign so that you will refill
Wow.
my prescription for my estrogen, because I'm miserable and I can't think clearly. I can't remember where I'm putting things. I'm searching for words. And I said, well, have you been worked up for dementia? She said, absolutely not, because this only started after you
Oh,
stopped me
mm.
from taking my estrogen. And so in my mind, I'm like, okay, well, she's like, just tell me where to sign. I'll sign whatever you need to sign to say, I know I have a risk for stroke or heart attack. She said, but you want me to be miserable. I'm going to leave the earth at some point. Do you want me to have a great 10 years feeling normal? Do you want me to be miserable for 15 years? I'd rather feel normal and live the rest of my years feeling normal than you telling me I can't take this medicine because I might have a risk of a heart attack. Don't I have a risk for that anyway? Don't I have a risk for stroke anyway? I'm 70 years old. I mean, just if you could see it crystal clear, this patient was the one that you could see it crystal clearly that she did not have dementia. Really, the symptoms started when she stopped her hormone therapy. And once she was back on her hormone therapy, she felt normal again. And so, yes, there are going to be patients who get diagnosed with dementia. Absolutely. I'm not, and we don't have the proof that estrogen decreases that risk. And really, if we started older than 70, older than 60 for the first time, there are some studies that say that may increase our risk for developing dementia over our lifetime. So there's not really a recommendation to start it, especially if you're not having symptoms, just for the cardiovascular benefit, because that goes down after 60 as well. But what I see clinically is that patients have mental clarity. If they've come to me with brain fog and we start hormone therapy, that is a symptom that resolves with hormone therapy. Resolves.
There you go. I mean, it's
And
crystal clear.
yeah,
That's it. You can't
I
make
mean,
it. You can't make. I mean, that's a great story. You know what would have been really interesting is to look at a SPECT scan or a PET scan of that lady's
yes.
brain and see if actually just by putting her back on the estrogen,
Hmm.
she had increased blood flow to
Yeah,
her, her frontal lobes because it's so fascinating.
it
And
is.
the other thing I take away from it is again your holistic approach is just so important. Our focus has gone so like myop, it's so narrow.
Yes.
It's like, oh my God, you have this increased risk of this, and that with that. But then the patient's in front of you saying, Doctor, I feel terrible.
Yeah.
I would rather not live like this. I don't care. I don't
Hmm.
care. Now, of course, you're not going to put them on something that is a death sentence. That's a different
Correct.
problem. But
Yes.
if it slightly increases their risk of something based on one study or whatever it is,
Yes.
but you know that you're going to give them a great quality of
Quality of life.
because that has our profession and
Yeah.
it's just I think about this so much. We've gone away from true health and wellness and just we are so focused. We have all these elderly people now that yes, modern science can keep them around so they can stare in their nursing homes at the wall, right, in their
Mm.
wheelchairs for a long time. We can keep that. We could give them diuretics so that,
Hmm.
that we can keep their blood, we can control their blood pressure, we
For
can
sure.
do
Yes.
stuff, but they're just zombies, right? Just
Yeah.
sitting there,
Yeah.
and I've spent a bunch of time at these memory care facilities just because I just really trying to work on dementia and what we can do with these patients. There's no way to live, right?
No.
They just want to
No.
live. And so if people are getting diagnoses of dementia because they're not on their hormones, for God's sake, give them their
Yes.
hormones.
Yes.
They're 70 years old. Like you're not going to live forever. You know what? Once you're born, you're all in.
Yeah.
And
It's
not you're all in.
yeah.
That's it.
It's
That's it. So you might as well live the
gonna
best life
happen.
you can.
Exactly.
There's no way out of it. That's it. So, all right. Last thing, you touched a little bit on before we get. I want to just we'll dive into perimenopause
Yes. Yes. Yes.
specifically
Yes.
because I want to do the symptoms and then what is available for people.
Yes.
The other hormone, testosterone.
Oh, yes. Yeah.
So we see that, and I've seen a lot of some of these younger women that have lower testosterone levels, where their other hormones are okay. It's interesting because I would say again, Anna, this is just what I see because they also see me for other reasons, like
Yes.
integrative health, but I'm not managing their hormones necessarily. I would say like about half of them that are put on they're just put on testosterone therapy because their testosterone's low. Like it's a game changer, complete game changer. And the other half, it does nothing. And
Correct.
that's because even because they might have a normal estrogen, but yet they're not getting that, So at who do
Hmm.
you recommend testosterone replacement? You like in your like what's your outlook? And again, there's different camps. Like
Yes,
you
there are
said,
many different
yes.
camps. And so my camp is more of the ACOG Menopause Society camp. And it is really when we're talking about hypoactive sexual desire disorder or decreased
Mm,
libido. And so that's really when we kind of open the door.
mm,
Now, and I will say, I have not, when we start patients on hormone therapy with estrogen and progesterone, it is very rare. So I will say probably maybe one patient every 2 to 3 months may still then need testosterone. I will preface it with
interesting.
that. Where
Interesting.
when I see them for their follow-up, which we usually start and we do a 3-month follow-up, we might have to make some adjustments in the estrogen doses or the progesterone
Mm,
doses, but most of those patients are feeling normal at that 3-month follow-up. So if we're still having libido issues,
mhm.
then that's really where we open the door to testosterone for me. Now, we don't have an FDA approved testosterone for women in the first place in the United States. So that's one. And we've been using the men's testosterone, so
Mhm.
the
Yep.
the Testem and Androgel, where we just give a tenth of the dose
Right. Yep.
that the men would use. And really, if you get a 1 month supply, that should last about 300 days, right? And it's only, maybe 120, $140 for that one 300-day supply wherever you are. And of course, we check the level. So when we look at testosterone, we would check a baseline to see where you are, not to see if it's low, but really just to have a baseline so that once we start you on
Mm,
testosterone, one, to determine that you are absorbing it, and number two, to see that your levels are increasing. And then when we follow up, usually at six weeks, and then again at 12 weeks, we want to see how symptoms have changed or improved.
okay.
Because if we are seeing that we're getting you, you're absorbing it, we're seeing those levels improve, but clinically we're not noticing an improvement over a 3-month period, then we say you may not be a patient who responds well to testosterone
Mm,
anyway. Now, I don't do, I'm telehealth, so there's no pellets for me because I can't I can't
yeah.
place pellets, and I don't really support the pellet part of hormone replacement therapy just because, there's reasons. Um, but some patients will come with pellets, and even those patients that I see because they're getting pellets elsewhere, I won't say that it's 50-50, but I will say about 25% of them will say, I don't really feel like I had a difference with the pellet. And then we look at their levels because, of course, they'll, bring their labs to me. And even though we see that their levels aren't increasing, there are just some patients who don't respond. And so I'll get the patient who's come in and has only been offered testosterone and has never been offered estrogen or progesterone, or they haven't been offered it because, oh, estrogen is more dangerous than testosterone. Like these are the things that I hear when the patients are coming to see me. And I'm like, we can weigh the risk and benefits of all of them. I don't see a reason that we can't take the estrogen. Like but this is what is
Misinformation.
happening,
Yes.
right? And so we come back in and educate. But although you usually use it for the clinical indication of hypoactive sexual desire disorder, we do still see improved mood. We still
Mhm.
see
Yes.
even better sleep with the testosterone. So we see that with hormone therapy, but we also can see those benefits with
Mm,
testosterone as well. And I will say that some of my patients who only have done testosterone and did not do hormone therapy felt like they had more mental clarity with testosterone. You couldn't even compare it to estrogen because they had never even taken hormone therapy with estrogen.
yes.
So I've
Yes.
seen that.
Yeah, because a
Yeah.
lot of them will get started just on testosterone first
Mm-hmm.
because it's low. Because again, their
Yep.
other numbers are normal and they're,
Yep.
37
Yep.
years old. So they're like, well, you need some testosterone and
Yes.
let's see how you do. And again, it just depends. I mean, I've seen some patients, they're not getting it. But I think when I say 50-50, I think it's because some of them that get put on testosterone think they're going to get on testosterone and it's going to change every aspect of their
Everything.
life. And that again, right, it's like everything. It's like, what they teach kind of in Buddhism, right? When you think of when you're expecting something and you get something else, that's why we suffer so much.
Yeah.
It's you got to just accept, I don't want people to accept we're trying to help them, but you got to
Yeah.
understand what we're trying to, accomplish. Where you're not going to become superwoman from one thing regardless. it's
Correct.
it's a combination of look, I'm gonna ask you
Yeah.
one more hormone thing because it's something that like no one talks about. What about in patients, what's the this I really don't know the answer to, because there's a lot going on now in the world of peptides. I do a lot of
Uh-huh.
peptide, treat. I like you got to be real careful, but and it has to be it really. I think physicians really need to take the lead on peptides because it's complicated, and people are getting peptides from these influencers that know nothing, and it's very dangerous because they don't know they're on pills, they're on blood thinners, they're on all this other stuff. So
Hmm.
I've done a bunch of videos on that stuff. But speaking of stuff, growth hormone levels, is there a correlation between growth hormone levels and symptoms of perimen? I really don't know. I haven't researched that.
Not that I know of, and not in even in the studies,
Yeah,
to become
interesting.
menopause certified. There's really no discussion there about growth hormone.
Because
That's really interesting.
it,
Yeah.
it is a very it's interesting. I'm glad. Good. I'm glad. I
Yeah.
was like, I don't. I just
It's
it
like, yeah,
just
I
popped
don't.
up. It just popped up because I was just thinking because there are these there's these growth hormone secretagogues. In other words,
Hmm.
I don't want to use fancy terms for those listening. That they basically they stimulate your brain to then
Hmm.
produce growth hormone. So there's something called like CJC 1295, and there's like sermorelin and tesamorelin. All these
Mm.
peptides out here. Again, they're not. I mean, tesamorelin is actually FDA approved for something, not for that
For this.
necessarily. But you can stimulate people's growth hormone to
Hmm.
increase during the day. So I was just curious if
Yeah.
that's another aspect of it, because we certainly do that in the kind of the health and wellness space to just
Hmm.
get people feeling better and their performance gets better or whatever. So I was wondering if that potentially has any effect on like perimenopause
I have
symptoms.
not read
Yeah.
about that yet. No. Mm-mm.
All right. So we both
So that's
have
a good thing.
we
Yeah,
both have some we got both have
homework.
some homework.
Yes.
All right, to do on that. All right, we're going to get basic because people, they're like, what are all the symptoms? I want to know if I'm
Yes.
in perimenopause. So,
Yes.
what should women be looking for if they're just because they don't have, you said it many times, you
Hmm.
don't necessarily have to have hot flashes to be in perimenopause. So, can you just go, I know it's long, but just go
No,
through a list of
yeah,
symptoms that people can, like present. And then I want to start breaking down like parts of how we can
absolutely.
treat these things.
Absolutely. So, really the heralding symptom is into perimenopause is usually we start to see that our cycles are becoming more irregular. Now, again, no one is textbook. So that's the easy one.
Okay.
If you go into your PCP or gynecologist, you're like, I'm skipping periods, then they're going to say, oh, you're probably perimenopausal. It's an easy one because textbooks say that that is usually the first symptom that you experience as you're entering into
Okay.
perimenopause. So, and that could be any number of changes. It could be that you're skipping so that you are not having an actual bleed every month, or you're going 2 to 3 months between
Mm,
having periods, or periods are heavier
mm,
or lighter. So you can go either way. They could be longer in duration. So if you were, one who had bleeding for 5 days, now you're going 7, or you bled for 5 and now you're bleeding for 3. So some type of change in the actual menstrual cycle is usually that first symptom. But again, most patients are not presenting with that as the first complaint. So it really may be just a symptom of moodiness, or I'm feeling more irritable, I'm more tearful. It could also be, we mentioned, joint pain, and this can be anywhere. It can be back, knee, um, it could be ankles. For me, it was a shoulder. Like I just started having this shoulder pain just out of nowhere. And, patients sometimes will come in because they've already gotten a workup, they've gotten x-rays, they've gotten labs, and we've already ruled out it's not an arthritis, it's not, an autoimmune disease. Like, so I will see some patients who've already had a workup because of that. And again, improved symptoms starting HRT, but we'll come back to that. So any number of joint pain, in different areas or in multiple areas. Additionally, poor sleep. So either difficulty falling asleep or difficulty staying asleep. So, waking up at 2 or 3 in the morning, not necessarily because you're having night sweats,
mm,
Of course, that can happen though. So hot flashes and night sweats can also happen. And if you're having drenching night sweats, then of course you are going to get up in the middle of the night and you're going to need to change your clothes, or you've got to turn on a
mm,
fan or turn off the fan or get a cover and then take the cover off. Um, Skin changes. So we notice there are just random complaints of itchy skin, just
Mm,
with no rash, no dermatologic diagnosis,
mm,
just my leg is itching, my arms are itching. I just thinking through all the patients, there's one in particular who just no matter what she did before coming in, nothing had worked for this itchiness, and there's no visible rash, there's nothing there. Additionally, we talked about brain fog. So brain fog really can be
mm,
trying to figure out words, decreased ability to concentrate, forgetting where you left your keys, forgetting where you parked your car. There are some patients who come in with cardiac type symptoms. So feeling that they're having palpitations or a rapid heart rate. Now, not chest pain
mm.
or shortness of breath. So those, of course, we need to work up.
Of course.
But I definitely have had patients who've already had a cardiac workup before they've come in as well because they're feeling just those palpitations, just
Mm,
feeling like their heart is racing and have a negative workup. And then we start hormone therapy and that symptom goes away as well. Back to skin though, adult onset acne.
mm,
I've seen rosacea diagnosed. Um, of course, hair growth on the lip and chin. That kind of comes with the territory.
yeah.
And then thinning hair or shedding hair. Some patients with actually female pattern baldness that we may diagnose at this stage, telogen
Mm,
effluvium, which is another where your hair is just kind of in that shedding cycle chronically. It's from every part of the body. Then we go down to vaginal dryness. So we talked about estrogen receptors. And so the vaginal
mhm,
vulvar tissue has estrogen and progesterone. I'm sorry, estrogen and testosterone or androgen receptors.
mm,
And if we're not making estrogen on that cyclic basis, then that tissue will also start to get thin and dry and tear, which can lead to painful intercourse. It can
mm,
lead to more urinary tract infections, just discomfort just during the daytime, not even associated with intercourse, because that tissue is getting thinner. We're losing the folds that happen normally in the vaginal tissue, and we lose that barrier. So the pH changes, we lose the barrier really kind of between the vaginal tissue, and we've got the urethra and bladder really kind of up there
mm,
on the upper portion of the vaginal vault. And so that tissue is thinner. We see prolapse where we've kind of got a loss of that elasticity, and so the bladder is
mm,
kind of prolapsing into the vaginal canal. So those are, I mean, it's from head to toe the symptoms. Now, some of those symptoms might be worse. The vaginal symptoms may get worse as you transition into menopause and you're no longer making estrogen at all. But we see it even in perimenopause. And I will just stress this one thing. It is common for us to offer a birth control pill to a perimenopausal patient. Very common. Because usually remember I mentioned that first
mhm,
complaint is usually irregular periods. And so we've got a tool that helps to regulate periods, and it is usually a birth control pill. So it's in our toolbox. It's what we know. Like this is basic
mm,
training. Irregular periods, if everything else is okay and we don't have like another reason that the periods
mm,
are irregular and we do all that workup is normal, then we say, here, take a birth control pill. Well, birth control pills are designed to keep us from reproducing, right? So our normal cycle is pro-reproduction. So when we're having those
mm,
rise and falls of estrogen and progesterone, it's because we're ovulating. We've got an egg that has now been ovulated, and that we've got a window to fertilize that egg.
mm,
So when we are reproducing, our body's goal is to get the egg fertilized.
mm,
So we've got a 72-hour window, and we get normal signals. We get hormonal signals that push us towards reproduction. So it may be that we feel desire, we feel excitement if our partner who can fertilize this egg has passed by and we smell their scent in the air or we see them because our body is saying, you've got a window, let's reproduce. A birth control pill stops that. So
mm,
if you come in and say, I'm having irregular periods, my libido is low, I don't really want to be intimate, I'm having vaginal dryness. Well, guess what happens when we put you on a birth control pill? You're not going to get any of those signals anymore because now we've stopped all of those hormonal signals. So your libido was low, but we gave you something that's going to tell you that you shouldn't reproduce. So now we're going to drop their libido even more. You may experience more vaginal dryness because even though this birth control has estrogen and progesterone in it, it's not the same as the estrogen and progesterone that we use for hormone therapy. This one is designed to tell our brain, shut
mm,
this thing down, stop the ovulation, stop the signals. We don't need to have those signals this
mm,
month or as long as we're taking the pill. because we don't want to reproduce. But it does keep us it keeps the cycle regular, right? Because now your cycle is not that normal cycle. It's because we're changing it with the birth control pill. And so I think the biggest thing, if I could just say to primary care physicians, we might not want to just start with the birth control pill when we're starting to see perimenopause. Now, if we are at risk for an unintended pregnancy, hormone therapy will not prevent that. Hormone therapy is not a contraceptive. So those patients who still need contraceptive therapy, we still have to figure out how we're going to provide that if we aren't going to give them a birth control pill. If we're going to, could we do maybe an IUD that goes inside the uterus while then giving them hormone therapy with estrogen? That's a great option, especially a progesterone releasing IUD like a Mirena, because then they get that uterine protection, but then we can also give them an estrogen patch to really help with the symptoms versus the estrogen that we would give in a birth control pill. So I think I went on a little bit of a tangent there.
No, I think that's great. No, I think that's no,
But
that's fantastic. And I mean, this is, I'm sure that women are going to watch this and they're going to have all kinds of questions. I'll push them towards you, obviously. We'll go. So
yes,
I wanted, there's so many things because obviously women are, half the population, right? So
yes,
we like how we get to this point where where you're giving advice to doctors. Hey, this is
yes,
how you treat this thing. Like
yes.
it's frustrating, and that goes for for so many different things. But I want to just drill into a couple of things that
Yeah.
are of interest. Hypoactive, this hypoactive sex,
Yes,
sexual,
yes, desire.
arousal, all this stuff. It's important. And like I told you before we started the show, even as a spine surgeon, people have been disclosing this to me randomly,
Yes,
right? Like they
yes.
just want to talk about it because they're like, is it coming from my spine? I'm like, no, it's not coming from your disc bulge. That has nothing to do with it. Please go see your primary care provider. I don't really want to talk about this stuff. Now I do because like the
Yes.
integrative health thing.
Mm-hmm.
But it's really fascinating because it's like a lot of women live in, just in silence about it. They're embarrassed. They don't want to say anything. They feel guilt. They think there's something wrong with them and they don't come out. And some
Yeah.
just don't have the right, or they just get blown off, or they say, oh, go do this or go do that. But, I want you to talk about that. There are real solutions and therapies. I know I mentioned peptides, there's that PT
Mm-hmm.
141, which is great, right? And I think I believe that's approved for
Mm-hmm.
that. I believe. I'm not
I'm
sure if
not
it's
sure about
approved, but
that.
it would be approved for. I know I'm almost positive it's approved, but whatever. That's not something that
Yeah.
that I have anything to do with. But what are the options for women that are having it? We talked about obviously replacing their hormones is great.
Yes.
What about creams and
Yep.
other?
Yeah.
You just
Yes.
tell me what should people know?
Yeah. So really, we've got multiple ways to treat hypoactive sexual desire disorder. And the first thing is that we have to be able to talk about it, right? And so you mentioned,
Yes.
a lot of patients won't really discuss that part. And sometimes, in certain physicians' offices, the question isn't asked. And so I think, the biggest thing is that we have to be open to say, what is your sex life like? Are you having pain? Are you having, desire? Do you not have desire? To just
Mhm.
open it to make it more of a normal discussion. It's not taboo. But I think once we kind of are able to talk about it and realizing that there doesn't need to be guilt or shame associated with it. So really, for my patients, some of them will come in and they feel again that there's something wrong with them, or they think, "Am I just no longer attracted to my spouse?"
Mm.
The basic thing we just talked about is just understanding we're not in that reproductive age range anymore. So we're not going to get those spontaneous signals that we used to get. So just like you might need bifocals, you may need tools now to help with
Hmm.
desire,
Hmm.
right? We got some changes of vision that are happening as we get
Yes,
older.
that's a
We
great.
we should also
Yeah.
understand that there's going to be changes related to desire in our sexual
Mm.
response. So first is communication. I openly invite patients to talk to their partners to explain what it is that they're feeling, whether it's pain or whether it's not being able to have that desire. I offer some book references, which I'll kind of give a few of those as well. But then we also have counseling. So there's therapy, there's sex therapy,
Hmm.
there's couples therapy. You know, when we talk about libido for women, it is more multifactorial. So usually there's multiple things going on. And when we're at this point in our lives, do we still have kids that are almost out of the house? Are we dealing with the fear of becoming empty nesters or the fear of kids leaving and going to
Yes.
college? You know, are there other emotional components that when you decide that it's time to be intimate, all of those other thoughts are now racing through your brain? Absolutely, you know, that's the case for many of my patients. Um, Once we kind of dive through those things and we say, well, I'm ready to try medication as an option, there are medications available. Of course, as I mentioned, sometimes hormone therapy is really just
Yes.
getting that
Yes.
balance, and
Yep. Yep.
that's enough. But if that's not enough, that's, you know, testosterone definitely comes in there. That's an option. And we kind of talked about that in detail of how
Hmm.
we would use the men's gel and do a dose that's about a tenth of that. And but what if that doesn't work? Or whether the patient is just, you know, doesn't want to take
Yep.
testosterone. So we do have two FDA approved medicines, and they still are both the brand name medicines. We don't really have generics. I think there might be some compounding pharmacies that are
Hmm.
making bremelanotide, which is it's the generic
That's,
name.
I looked it up.
Um,
That's the PT one.
oh yes, okay,
That's PT 141.
yes,
Because I
that's
was going
it,
to say, yeah, the
that's it.
compounding
Yeah,
pharmacies,
yeah. So
yeah,
they're making it.
right.
Yeah, so that's bremelanotide, and it is an injectable medicine.
Mhm.
So the brand name comes in a auto injector pen, and they usually come as 4 pens in a pack. And that I it's just my lowly opinion, but I will tell you, I think that it is the best thing that I've seen in
Really?
terms of
Hmm.
yes, yes. Now,
I'm gonna
but just
write this
like
down.
testosterone, yeah, please,
I'll
please.
write this down for
But
our
just
patients.
like
Yeah.
testosterone, it doesn't work for everyone. But the good news about that one is you'll know after the first dose if it works or not.
Mm.
So for that one, we usually recommend taking about 45 minutes before planned activity. I don't recommend it that way. I just say to patients, pick a day next week. Say it's Monday or Tuesday. Pick a day. That's the day you take the shot. Do it maybe 2 hours before dinner. I do recommend taking an anti-nausea medicine
Mm.
because across the board, I do not know a patient who's taken it who has not gotten nauseous with the medicine. And even the reps recommend that you prescribe an so like an oral disintegrating type tablet,
Mm.
maybe about 30 minutes before taking the injection.
Because
Okay. And
nausea is not going to help all that, whatever you're doing. Nah, it's not going
it's
to help. All
not at
right.
all, not at all. It's going to be totally the opposite.
Yes, yes, yes.
Um, but if I could have some testimonials from patients, just so let's go back. So take the
Yes.
nausea medicine 30 minutes before the injection and then try the injection. And don't anticipate, just say, this is the day I'm going to take it. I'm just going to see what happens.
Mm.
But when it works, usually you do have some flushing, some facial flushing. So your face gets
Mm.
really red and warm about 20 minutes after the injection. It the reason I say don't do 45 minutes is because I haven't seen anyone respond within 45 minutes. It's been
Okay.
more like an hour and a half to 2 hours.
Gotcha.
And while it says it works in the brain to
Mm.
increase desire, what most patients describe to me, and from personal experience, I feel like it's more similar to Viagra, where you actually feel blood flow in the genital area. So that is the
Mm.
best. And for those who have taken the medicine and it's worked for them, they describe that as well, that there's just more of a fullness, just blood flow to the genitalia, which, you know, your Cialis and Viagra's do, you know, do the same thing. And that remains very intense until an orgasm happens. That's the
Mm.
best way for me to describe it. This is not how the reps describe it. It's not what the literature says. This is clinical from what I have experienced myself and from other patients. And so, again, it may not work for every patient, but for those who have, they know within that first injection.
So basically, this is the women's blue pill.
I think it is. That's my opinion on it, even though we have a pill and we'll talk about that one as well.
Yes. Yeah, yeah.
But that one, I don't, it doesn't quite do the same thing. Even though when it came out, we thought, oh my gosh, this is going to be right. I think the shot is more like, so the injection works more like that. Now, I have gotten it covered by insurance very rarely.
Yes.
If it's not covered, the the 4 pack box is usually somewhere between 199 and 199. You can only take up to 8 injections in a month. You can't take more than one in a 24-hour time frame. So that one box of four is usually all that a patient will get for 1 month just to see if it works.
Okay.
And it's been as cheap as 99. And so really it's a $99 investment if it's not covered by insurance. So it's, about $25 for one injection to know if it's going to work. And if it works, then we're getting refills. If it
Then you,
doesn't, then you're like, okay, so this didn't work for me. Now, I've had a few patients who have tried it in different scenarios, just because that first injection didn't
mm,
work. Try it without food, try it,
or they
before
were
I
no,
eat, try it after I eat.
or they were so nauseated that they were just,
Yeah.
in the
Yes.
bathroom the whole
And
time.
I have
Yeah.
seen that
Yes.
as well. And
Yes.
so I only prescribe it with an anti-nausea medicine, but I talk about it, and so I get some feedback from people who maybe didn't get
So
an
what do you
anti-nausea
what do you
medicine.
use for anti-nausea medicine?
I usually use Zofran, just the oral disintegrating ondansetron.
Not like
Yeah.
a scopolamine patch or
No,
anything like
no,
nothing over the top.
no.
Okay, gotcha.
Yeah, that pretty much is all it takes is just one. Now, when you talk to the reps about the medicine, they say it's usually you only need that anti-nausea treatment, the very first injection.
Mm.
I prescribe
Mm-mm.
it for every injection. Yeah, we're not taking chances
And
because
what's the half-life on
I
that
think
drug?
it's 24 hours. I
Wow.
think it's 24 hours. I can look it up. But yeah, I think it's 24 hours.
It's just
Because what happens,
yeah.
again, this is not what the literature shows, but this is clinical feedback from patients, is that, after the first orgasm, that sensation is still there, but it's just more dull. And that
Gotcha.
pretty much is there for 24 hours. So some patients will have multiple experiences just with that one injection where they're not really needing to take 2 injections a week because that one gave them multiple episodes, just with some positive feedback too, right? Because now you've had a pleasurable experience
Mm.
and you want to see if you're going to have another pleasurable experience. And so there's a positive feedback to that, really, with or without a shot. If we have a conversation with our partner and we focus on talking about what we need or what feels good and what doesn't, and we then build on that and have a pleasurable
Mhm.
experience, there'll be positive feedback to say, well, maybe I'm willing to try again. And so in that libido area, there's so many ways to kind of come in and work on improving that connection and improving the experience, that then we have positive feedback. So I've had some patients who've taken the injection and we did maybe 3 months of refills and they don't need it anymore. Because then
Mm.
there was discussion. Now there's a closeness that's come back because we're taught, like,
Yes.
I
Yes.
just, yeah, so it's so multifactorial that I mean, I have some patients who get the prescription filled every month, but then I have some who don't need it anymore or don't feel that they need it anymore. Oh, I was going to tell you about the half-life, but it is probably, I think it's been out for maybe I think 2017 or 2018. And it really didn't get much. We weren't prescribing it because it wasn't covered and it was expensive and no one wanted to take an injection, right? But now with injectable GLP-1 agonists, like,
Yes. Now
it's so much more common.
we're training everybody with it.
So, so over the last probably 2 years, maybe 18 months to 2 years, when I mention it now,
Mm.
patients are like, oh, well, maybe I'll try it. Where, 2 years ago, they're like, oh, I don't want to take an
Because they don't
injection.
want to inject.
Yeah,
People are
yeah,
fine to inject now. I
yeah.
know what you're
They're
saying.
happy
Like,
to. Yeah,
absolutely.
yeah. Oh yeah. So I was gonna just look that half-life up really
Yeah, and then
quickly.
after that, you were gonna talk about
Oh, the pill.
the other approved
Yes. Which,
medication. Even though it sounds like
yeah.
this is the go-to. This is the
Yeah,
go-to. We'll
it is. It is. It is.
we'll push him on social towards this direction.
Okay, it is not 24 hours. It is 2.7.
But that
2.7
doesn't. But
hours.
it's still
But
around.
it's
I know
still,
it's still around. It
yes,
was more
you
like it's
still
around
feel
the.
it.
Yeah, you're still
Yes.
around. It's no different than like Cialis. It's
Yes.
still around, and that's why.
Yes.
So that's the reason I asked you about the half life. Not that I'm a pharmacologist. We don't have to
Yes.
get deep into all the pharmac. The reason I asked you that is I was wondering why the restriction on the number
The
of doses per
in
month.
24. Mhm.
Is it a symptom thing, or is
Well,
it because you build too much of it up in your system?
well, let me talk to you
Oh,
about that one
okay.
part. So there's another part of, and it works. Um, in that part of the brain. It's like a melanocyte
Yep.
receptor agonist or antagonist. And I can't, don't quote me on which one of those it is. But in the clinical study, so when they were developing this
Mm-hmm.
one, they did see an increase in hyperpigmentation
That makes sense for
in
melanocytes.
yes, in
Yes, makes
patients who
sense.
took more than 8 injections a month. Now they quoted as 1% of the patients who took more than 8 injections a month. I don't know how that got to the one in 24 hours, but definitely more than 8 injections in a month may result in areas of hyperpigmentation anywhere in the body, face, breast, genitalia, anywhere in the body. Have I seen that? Yes, and I've seen that in patients who have not taken 8 injections a month.
Interesting.
And so, of course, it's going to be more common in those who have more melanin to start with. So it's going to be more common in those patients, but definitely I've seen it in the past year. I've seen it in one patient, um, and it was just there were little hyperpigmentation spots on the face, and they did go away. But there's no follow up to know if these
Interesting.
resolved. So if you look at the study in
Mm.
the insert, because we tore it apart, myself and one of my dermatologist friends, because I really wanted to be able to, present
Of
the
course.
entire,
Yes.
these are all the possibilities. But, I've had a patient who said, join the rest of the dark spots on my face, bring it on,
Bring it
and
because
so, 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 again, as we talk about, risks
funny.
versus benefits, if it works and you now have this, sex life sex life that you've never had before, then you may decide that you want to take that risk. Again, they say no more than 8 in a month, but I've seen it in a patient who
That
had less
may,
than
I
8.
mean, that makes sense. So the other
Yes.
medication, is that the one that improves blood flow or works kind
No,
of
it doesn't.
similar? Or
It's
no,
it's
the other one. I know the PT-14,
yeah,
that's a melanocyte,
yeah, yeah.
what is the other, what's the other one?
So
And
the other one is flavanserin. The brand name is Addy, ADDYI. And it doesn't increase
Mm,
blood flow. It works with dopamine and serotonin. So
mm,
it almost works similarly to some of the anti-anxiety antidepressants. So this one also is supposed to work in the brain. Now, this is a tablet that is taken orally every day,
mm.
and it may take up to 8 weeks to know if it's going
Right.
to work for you. In the clinical studies, what they quoted was that patients who took the medication experienced one additional pleasurable episode a month. So that one is a little bit more difficult to sell, right? And I have not, this one came out, I'm almost sure in 2016. We were very excited that it was coming out
Of course,
because
yeah.
we thought this is going to be the
Oh.
Viagra. This is going to be the pink blue pill, right?
Hmm.
And when it initially came out, it had a black box warning that you could not have alcohol with this medicine for risk of a syncopal episode or fainting. And that black box warning got removed. Just the way that they did the clinical trial for it, it was first thing in the morning. Patients hadn't eaten.
Hmm.
They drank like 2 beers or
Oh,
three
yeah.
beers, and it wasn't realistic. And so they changed the warning to, well, they removed the warning, and they now have a disclaimer of if you're going to have more than two beverages in one evening, skip that night's dose. So we tell you to take it at night before bedtime. And so if you're going to have more than
Mm.
2 glasses of wine or 2 cocktails, then that night you don't take your dose of medicine because of the
The
risk
syncopal.
of a syncopal episode. I have not had anyone who's continued this over 3 months because
So
it
I'm gonna
just has not.
let's X that one out because I mean the way you described the other one and this one, I would just X it out. But this I mean this is real important. This is like real important stuff, like the differences between the male brain and the female
Yes.
brain and the way it all works. It is how interesting is it that all the male drugs are all about improving blood flow.
Yes.
The female drugs target the brain.
The brain.
That tells you
Yes.
how different
Yes.
it's different buttons. You're pushing totally different buttons, and everybody know. I mean,
Correct.
everybody knows this, right? It's a
Correct.
lot different for women that it is for men. But it's so interesting that the technologies, things that are getting approved, are
Yes.
exactly the
Yes.
opposite. One,
Well, and
even though the other one sounds like it's doing its thing, but maybe it's stimulating the brain then to then you're getting all those blood flow changes because your brain
yes,
is different.
correct.
Yeah.
And with this one, with the tablet, there have been there have been like some I can't remember what journal it was in, but it was one media release maybe last fall of a patient who talked about how it changed her
Mm,
sex life and also helped with some anxiety symptoms. And
mm,
of course, because it works similarly, we may see an improvement in just a small improvement in
of course.
someone who might have some anxiety or depression type symptoms. But then also, if we're improving that, is that also going to give us positive feedback? Absolutely, to that whole desire loop. So again, when we're looking at libido, we have to look at what medicines are you already taking? Are you taking a medicine that is already going to affect your libido? Biggest one, your Lexapros, your
Right,
Zoloft,
right.
all those
Horrible. Yeah.
SSRIs.
Yeah.
We have to look at that. And then we have to weigh, is it worth us changing this to maybe a bupropion that may not have that sexual side effect, but then may increase a little bit of anxiety? Like you have to really kind of, again, it is not a one size fits all. We have to look at each patient individually and look at that list of medications. Is there anything here we can adjust? Is there anything here we can add? Is communication going to be the biggest key, or even just reading books that kind of walk you through what's happening now? So, there's multiple options. There's Come As You Are, and we can put those in, in the notes if you want. But there's a Tired Woman's Guide to Passionate Sex. So there are some options that just kind of walk you through what's happening. Like I mentioned, we can't expect to have that 20-year-old libido because that 20-year-old brain had a goal of
Correct.
reproducing, and
There's
we
no
don't
script.
have that
Yeah.
20-year-old brain. Yeah.
Continue. That's what, our species has been around for 300,000 years. There's a reason. There is
Yes,
like all these
yes,
species, right? There's a
yes,
drive to continue the
yes,
species. It's literally,
yes.
it's programmed into our DNA. Okay. So I want to wrap up this because this is an important, like, this is a really important topic.
This is my
And
passion.
and
Yes.
it's very important for people's quality of life, right? Because for a lot of people, if they used to have a fairly, normal sex life and then it's absent or non-existent.
Hmm.
There was just I just saw it on like on X or something like that. But there was this study that was just showing how many, people are almost becoming like celibate, or the frequency of sex is
Mm.
going down. So I mean, anything that we can do to help. Now, a
Yes.
lot of that is because they're looking at they're staring
Well,
at
yeah.
their phones and
Yeah.
their brain. You talk about breaking our brains, like we
Hmm.
just think about different things. But
Well,
just go ahead.
well, I was
No,
gonna say we didn't talk about
yeah, yeah,
vaginal estrogen, that part, and I
yes.
don't know if that's where
Oh,
you were going.
yeah,
Yeah,
yeah.
I mean,
Other things.
yes,
Yeah,
because it may not necessarily treat the hypoactive sexual desire, but if we are having vaginal changes and vulvar changes, the tissue, the
right.
genitalia, if that tissue is not stretching, if it's dry, if it's tearing, then that of course we're going to want to avoid anything
Of
in
course.
in any type of contact in that area. And so vaginal estrogen is a treatment that we use perimenopause, menopause, or even in reproductive age women who take a birth control pill, because they too
Hmm.
can have the effects of menopause on the genitalia when they take a birth control pill, because remember, it's shutting everything down. So, vaginal estrogen, multiple options. There's vaginal estrogen cream. There's a DHEA suppository. The DHEA
Hmm.
then gets converted to estradiol and to testosterone. Not enough to be systemic testosterone, of course, but just to
Locally.
the vulval
Yep.
tissue. Um, there's a ring, there's a tablet, and then there's another suppository that is just in a like a coconut oil shell.
Hmm.
So vaginal estrogen is considered local, so it is not a systemic therapy like hormone therapy. So menopause hormone therapy goes throughout the body. Vaginal estrogen therapy just targets the vaginal tissue, the vulvar tissue, the clitoral tissue, the bladder, like all of that. And it helps to thicken the tissue. It helps to bring moisture back to the tissue. So we increase our glycogen storage in the
Hmm.
tissue once we give it estrogen, and suddenly now we're making more moisture. And that is something that we usually recommend, that once we start it, we take it forever. It may not be one method that is every single night, but it might be twice a week. so that we are all, because once we're menopausal, we're never making our own estrogen again. Like we're never going to make our own estrogen. So while hot flashes and night sweats we consider temporary symptoms,
Hmm.
those will eventually resolve. What's happening in the tissue that has an estrogen receptor that never gets estrogen, that's not reversible. That's not going to get better with time. We have to continue to provide estrogen to that tissue in order for that tissue to maintain its thickness and its moisture. And so vaginal estrogen is something that we usually would recommend really once we're menopausal, or if we start having symptoms prior to menopause, and if there's pain with intercourse. And we've ruled out now, of course, we need an exam. We need to
Of course,
look to
yeah.
make sure that there's not something else going on. But once we've done that, usually we're able to just by looking, we usually with one exam know, oh, it's a lack
Mm,
of estrogen. This is estrogen deficiency that's happening in this tissue. There are some other creams that are more for hypoactive sexual desire disorder that may be compounded that have a little bit of testosterone in it,
mm,
and sometimes a little bit of the components for Viagra or Cialis mixed with an estrogen base, or just a
mm,
neutral base that you can use just directly on the tissue of the
mm.
clitoris. And so that's something that is an option, but usually has to be done through a compounding pharmacy. And that is sometimes usually helpful to, of course, start with an um, an encounter that is pleasurable that then gives you that positive feedback where
Yes.
you open the door to want to continue to experience intimacy. So
Yeah,
yeah,
I,
just
I I think that that's I mean I think that that's great. You know, it's interesting because I'm very much into these light therapies and laser therapies, and there are studies out there that show that like direct like class 4 laser stimulation of that
mhm.
area can really help
Yeah,
with
yes.
all those things. And I really, I mean, outside of these like integrative health and kind of aesthetic clinics, that's not something that's common at all. If you talk to any, primaries, they have no idea what,
Mhm.
you're talking about. I mean, we don't do it for that, but certainly we do a lot of laser therapy for a lot of things, like including like Bell's palsy and all kinds of stuff.
Mm,
It's amazing. And the literature is really strong in so many different areas. So that's something in the future, and it's to be honest, even though it's out of pocket, like light therapy is so low cost, for
mm,
people to do. It's just
yes.
another, thing to add in there. What do you think about, and this might be a little bit, off on these people that are having, do you think that these, like these transvaginal laser therapies and things like that, does that help with that, or is that more for just tightening,
No,
reasons and things, things like that?
no, I mean so we don't really have a lot of data on follow-up for those, but yes, it's to help kind of get the tissue
Mm,
tighter, but also that it helps with dryness. And
mm,
so because it's helping to rejuvenate that
mm.
tissue, that you're then getting that tissue that with the glycogen storage again. And so
Yes.
now you're creating your
Mm,
own moisture. So it's really for that. We used to call it vaginal atrophy. Now we call it genital urinary syndrome of menopause, which is when that tissue
mm.
is
Okay.
lacking the estrogen receptors and the tissue starts to change. And so I definitely have seen patients who have had improvement of pain because they now have more moisture, but also that they feel like the elasticity has come back
Yep.
with like a Mona Lisa therapy, one of those vaginal therapies.
Yeah, like these
Hmm.
Thermiva
Hmm.
lasers and all these other, different things, which I'm more familiar with because some of our providers do
Yes.
do that stuff. And sometimes it's just like, because I just read about it some, and I'm just like, oh, I'm not sure, like exactly what are you targeting? And they're like, oh, it gets everything, like, but I'm like, okay, it
Yes.
gets everything. What about PRP? What about the O shot for patients? What have you heard on the O shot?
Well, that there's just, there's not really the literature to support like where we've got numbers to say, yes, we see this improvement. And I will tell you, for that, I've just kind of seen patients. uh, It's one
Mm,
of more of those
just anecdote.
50-50.
It's an
Yeah.
an
I
anecdotal.
I think that it's, more of that placebo type effect, where you have a high expectation. And again, you're excited, right? Because you've done something new. This is
Yes,
supposed to work. So you
yes.
want to see what this orgasm is like. So it opens the door for you to have the intimacy because now you've got this and you want to see. And so I don't really know if it's necessarily that the quality of orgasm is better, or is that you had more anticipation? And I just don't have the literature to say either way. But I've had patients who've gotten it who said, oh, I didn't really experience anything. And then I've gotten, I've had those who say, okay, I'm going in and I'm going to have this every 12 weeks. Like I'm going back because I feel like this has made
Yep.
a big
And
difference.
that,
So
yeah,
it's kind of
well,
hard.
I'm sure Dr. Runnels has done really
Yeah.
well with his with the development of these things and
Yes.
his the books with the like
Yes.
flower on it and say, oh, all this stuff. It's interesting. This stuff is interesting. Like I said, I never thought in a million years that these
That
are
you'd have this discussion.
conversations that I was going to have, but
Yes,
it's so important because if you're
it
just going
is.
to treat people and say, hey, how can we make your life better? They're going to say
They're
whatever.
gonna say,
They're going
yes.
to say like literally whatever comes, and every single person's different. Some people want this. Some people just want to like
Hmm.
be smarter. Some people want it's just pretty crazy. Couple more
Yes.
topics. Um, the brain stuff, right? These we keep talking about it.
Mhm.
I'm pretty fast. I mean, a lot of women, even in my practice, before I even got in down this path, just so many of them seem like they do have a lot of anxiety and depression, and it's a big, it's a
Mhm.
huge topic. And honestly, men and women, they just experience it a little different. They're just different. So do you find that a lot of their depression symptoms go away with just the estrogen treatment? Because one other thing I want to say, because we do a lot of this at our clinic. So I talked about the light therapy to the brain, which can stimulate, basically blood flow, and it cleans out, like it's good for the lymphatic system of the brain. It does all kinds of stuff. We use it for concussion, all kinds of stuff. So that can be very positive in depression. But
Mhm.
one of the things that's really really interesting in treating anxiety and depression is utilizing TMS, or transcranial magnetic stimulation, because it's
Mm.
drug free. It has been FDA approved for resistant depression for a long time. And some people choose to get that instead of ever getting started on
Mm.
an
Wow.
SSRI. And with the newer, like the newer models of things, like we use something called the Exomind for our TMS. You only need 6 sessions.
Mm.
And some of the results are like it's dramatic. I didn't know anything about TMS until I had this like TMS expert on my podcast like a year and a half ago, and then I got into it. I was like, we need to bring TMS
Wow.
into our clinics. Really fascinating stuff. So I just want to get your thoughts on the kind
Yeah.
of percentage wise, anecdotally, not in the literature,
Yeah.
what percentage of people, just from treating them with hormones, do you feel like their depression, anxiety goes away? What do you like? And I just think that if we can avoid those SSRI medications with other things, like I mentioned, it's just better for them. So, like even on our clinic, we try to get them to, work with their psychiatrist. But
Hmm.
if they're doing
Yes.
well with the TMS therapy, then come off of those things, because a lot of their symptoms are because of that. It's nothing else other than they're on Zoloft,
Yes.
and they don't
Wow.
feel well.
Yeah.
So anyway.
It's yeah, so this is anecdotally, right? Like I don't have the
Mm,
literature to say this is what we see, but I would say in clinical practice for me,
mhm.
probably about 70 seventy
Wow.
five percent of patients, I think, who have never had a diagnosis prior to, 'cause, like they did not have a diagnosis of anxiety or depression. They came in with complaints of those symptoms, but had
Right.
never been on. So these are the patients who have not been on any medicine, and we've put them on hormone therapy, and they're better now. But more patients come who are already
All right.
on
Yes.
on SSRIs, and we're adding hormone therapy now with those. Many
Of
patients, when they come in, they're like, I want to eventually come off of my XYZ,
course. Of course.
right? And over the course of maybe 6 to 9 months, we may have those discussions. And in the last year, I can think of just off the top of my head, I wasn't even thinking about this, but when you said it, I can see two right
Yeah.
now who have stopped. And this is with their therapist and psychiatrist on board. But the other concern I have is that a lot of the patients that I see who are already on an SSRI have never seen a therapist, have never seen a
E-
psychiatrist.
Exactly.
And so it was started because they went in and complained about a symptom, and we never
Mhm.
really did a deep dive, but we just gave them the medicine. And so then I'm coming in to say, well, let's meet with a therapist. Let's maybe, for some, meet with a
Hmm.
psychiatrist as well. And so if we're not doing full, behavioral therapy,
Right.
we're missing something. If we're writing an anti-anxiety, antidepressant, but we're not then providing the resources that should be going with that, then we're missing a big opportunity. And so sometimes just getting a patient in to see a therapist on a regular basis, in addition to starting hormone
Yes.
therapy,
Yes.
is all we really needed in the first place. Again, when we're at this point in life, there's so many other factors that are affecting our mental health. Again, are we sending kids off? Are we becoming empty nesters? Are we now rediscovering a relationship that had been really surrounded by raising kids for the last
Truth.
20 years? And now
Yes.
we're looking at each other trying to figure out what do we have in common now that the children aren't here? What did I love in the beginning before we ever, brought the kids into this relationship? And so there's that component that's also happening. So is it that we're having anxiety and depression, or are we having normal feelings because we're now in this stage of life? Another thing that I've seen is a lot of women in this 40 to 50 age range being diagnosed with ADHD, with
Hmm.
ADD and ADHD, who maybe have been so consumed in working, raising a
Good.
family, that they were high performers who didn't realize that there might have been something else, that we missed it because we're so focused on everything else
Hmm.
that we're doing, that suddenly now, and of course, if with untreated ADHD, we may see more anxiety, we may see more depressive symptoms. And so I've definitely seen that in this age range where patients have been started on treatment for ADHD and then felt like anxiety and depression symptoms have resolved. So there's so many different parts when we hit this, hormonal transition, that we're also hitting other milestones in life, and they're all coming at us at once. And we may need to look at each component really to be our best self, and to be able as physicians to look at those components to be able to treat our patients in the best way that we can.
No, I
Yeah.
mean, it's, it's funny. The same theme keeps coming up, right? It's complicated.
Yeah.
And that's
Yeah.
why it's really important for people to seek counsel, like from experts like yourself when they're having these issues, because let's be honest, the just the primary care community right now is not equipped. They don't have enough time to spend with these patients. It's just a different, I can't explain. Listen, I love my fellow physicians. I think it's great. I have this book coming out, and I give the doctors a pass. I'm like, I know some of you guys are in
Yeah.
these silos and whatever, and you're being
And they've got
forced.
so much.
They have
Exactly.
so much on their plate, but and like, right, these people come in and you say, okay, well, why are you here? I don't feel good. Well, how are you going to figure out how they don't feel good in a 15-minute visit? You
You
can't do
can't. You
anything
can't.
in
You
15
can't.
minutes. And so, that's why I'm doing that, like, like the integrative health thing, because
Yes.
you have to figure out what's the totality of it? Is it a psychosocial issue? Is it a true mental health problem? Is it
Hmm.
is it just because they've got this, like, a serious problem? They've got like underlying cancers,
Yes.
whatever. And if you're not going to see physicians that are just experts that have really been trained, but also have an open mind, so many things are going to get missed. And then you get the pen going, right?
Yes.
You don't feel good? I only have 3 minutes left, so I'm just going to put you on Prozac, because they don't have anything else to do. Or instead of getting like like a big a panel of like the apolipoproteins for
Hmm.
the stuff, they say, oh, your LDL's high. Oh, right away you got
Here's
to
your
be on
statin.
Lipitor or whatever,
Yeah.
or
Yeah.
all this stuff. Like they it's just because that's the tools that they have, because you have to talk to patients and you have to have these conversations. My partner, Dr. Belchi, she's a neuropsychiatrist, and she talks about this. She does a lot of cognitive behavioral
Mm.
therapy with people and things like that. And she's like, it's missing. She's like, these patients come in and they're just loaded on medications,
Yeah. And
and
never
nobody's and
never had the option.
they've never even had a psychotherapy session. They
Mm.
haven't done any of these things, and that is maybe all they need. They literally may never have been needed to
Yes.
be on these medications. So
Yes.
I think this theme of it's very complicated, and we just need to look at it from all these different
Hmm.
angles. Yeah, but what you're doing is great. So last thing, We have a lot of, actually, I'm going to do two more things. If you get that, I know we've been
It's
going
fine.
because this is great. I'm really enjoying, I'm
Yeah.
learning a lot. I'm taking like notes on stuff. This is what I do on the
I
podcast. You
love
know what?
it.
This is just as much for me as it is for my audience. I
Awesome.
love this stuff. I could do it all day, but bone
Same.
health, bone
Oh
health.
yeah,
This is
yes.
something I'm part. So this one, I like this. I talk about all the time. Okay.
Yes. Yes.
I'm a spy. So for everyone that's watching, okay, I have every day, I go to my office. I have these women come in. They're like usually they're 50 and up. They come in and they've got like five fragility fractures.
Mm,
Okay.
mm, mm.
It's like, and then I say, okay, well, this was coming. When did you get your bone scan? Most of these women have never even had a bone scan done,
Yes.
right? Until later in life. And obviously, people like more fair skinned people are higher risk. I mean, we can go into all that. It doesn't matter. So I have become, because we don't want to, as spine surgeons, we don't want to see these fragility fractures. And as an orthopedic surgeon by trade, hip fractures, right? Completely will ruin your life.
Oh.
All these wrist fractures, right? All this stuff. And it's because we're not picking up bone health or so there's 2 points. One, what's your thought? Because I am a big proponent of scanning women much, much earlier. There's
Then
something
the
called the
recommendation. Yeah,
much
yeah,
earlier, much.
yeah.
We have to change the reg. So there's something called the REMS bone scan. It is radiation free for those that are worried about like the DEXA scans, which isn't a ton of radiation anyway. But the REMS bone scan is probably going to going to become a superior product and really spread in the U.S. It is definitely spreading in Canada and in Europe. So that like that's one thing. And then the other thing is, how important is it to get these women started and fix their hormonal imbalance early?
Mhm.
Now, bone health is complicated. There's a lot of stuff. There's the thyroid, there's this, there's that, but certainly estrogen is
We
a biggie.
know.
It's a
Yes.
biggie. We know that
Yes.
it's period. It is known.
Yes, yes. So we know that, once we have declining levels of estrogen, we're going to see more bone turnover. We're going to see
Correct.
slower
Yeah.
growth of bone.
Yeah.
And estrogen absolutely it treats that. It helps to
Absolutely.
increase the bone density. It is FDA approved. So when we think about hormone
Mhm.
therapy, which I didn't really say this, but it's really FDA approved for three things. It's for treatment of hot flashes, night sweats, and to decrease our risk for developing osteoporosis. So
Bingo.
we have FDA approval for that, period. The reason that women continue hormone therapy is because of all those beneficial side effects of treating the brain,
Mhm.
brain fog and all the other things that we talked about. But what we know, and the Women's Health Initiative helped us with that. It was not designed to see if HRT or hormone therapy
Yes.
helped with hot flashes or night sweats. It was looking at these long-term outcomes of cardiovascular health and bone health and dementia. What we know is if we start you on hormone therapy within really preferably the first 5, but within those first 10 years of becoming menopause, younger than age 60, we're going to see improvement and lower risk for fractures later in
Mhm.
life. When we talk about the DEXA scan, which is that bone, the
Mhm.
bone health scan, technically the society support it, you having your first as a woman, your first scan at age 65. But there are multiple studies and there's literature right now and multiple talks going on of, do we get a first scan at 50? Do we get a baseline at 50 or 55 to just see where we are, even
Mhm.
before we start hormone therapy? So there's definitely good debate about why wait until 65. Like, why are we waiting until age 65? Really, and it's 65 to 70, but like I think men is 70, but for women at 65, do we want to just have that first baseline so we know and we're actually able to see what estrogen does, right? When we started.
Yes.
If we're menopausal at 50, do we get that first one at menopause prior to starting HRT? It's really a good discussion. There's a debate there.
Yeah, one of a good friend of mine. He's actually a men's health integrative health specialist. He used to be an ER doc, and then he left that because he was, like a lot of us, people
Mm-hmm.
get like they're like, I don't want to do this in the traditional system. So he left and he became this concierge medicine guy.
Yes.
So he gets
Yeah.
this DEXA scan and he gets a DEXA scan in his office and he does it for all his clients.
Mm.
And one day he just decided, I'm going to just do a little experiment. And again, this is all anecdotal. Don't worry.
Yes.
There's actually like there's literature
Yes.
behind why we're all pushing to do this earlier. But he just went around in his building. He didn't even know these people. He's in this huge building, and so he just went around and just knocked on all the doors and said, any woman If they're over 30, okay,
Mm.
he just said, "Hey, come down, free DEXA scan. I just got this DEXA scan. I want to scan everybody." So he scans like all these people. All the women are like, "Oh no, I don't need that. I don't need that." So they came down. 50% of the women he scanned were at least osteopenic. 50.
Wow.
Half of them were osteopenic. And so he's
Wow.
a big, big, proponent of scanning. And they didn't know. But then you look at it, who was osteopenic? Obviously, the ones that had some risk
Hmm.
factors, but sedentary lifestyle.
Yep.
A lot of, I'm a big proponent of exercise, especially because
Hmm.
obviously sarcopenia. I mean, keeping your muscle mass is one of the best predictors of longevity, period.
Hmm.
We know that. That's well studied. There's zero debate on that. And so when I ask women, hey, how
What are you
often do you
doing?
do resistance exercise? Even
They're
I'm
not.
talking bands. They're like,
Yep.
I haven't been to the gym in 30 years. And then I have to stop. And then we have to have a
Yes.
discussion about
And
sarcopenia and what that
yes.
does and longevity and mobility and being in a wheelchair for 30 years and all this stuff.
Oh, we
But
and
anyway,
that is part of the menopausal discussion as well, right? Like
huge.
just and they're like, oh well, I'm on the treadmill, I walk, I do a mile a day, but what else?
You
What are you
got it.
doing? Are you lifting? Are you doing resistance? Are you? Yes, absolutely. But yes,
No,
yeah.
resistance, resistance,
Hmm.
resistance. So anyway, it's interesting because he told me this years ago, and then I started really started looking into it. So I've been doing more and more scanning on my patients for a
Mm.
while, and we've picked up many women that have osteopenia way early in their
Oh
40s. I
wow.
mean, significant. Some of them have osteoporosis in their 40s. But they're the ones that are higher
Wow.
risk. So we kind of
Yes,
know
yes,
that,
yes.
right? We kind of know that because mom is bent
Yes,
over like a pretzel. So we kind of know
yes.
that you're going in that
And,
category.
and of
And then,
course,
yeah,
yeah.
yeah. But then we send them to the endocrinologist and they take it from there and they do their stuff. But the thing about it is it's so low cost. I get it. People say the DEXA scan. So there's something called the REMS bone scan. It's basically
Mhm.
an ultrasound and you do it for the hip and the back and it's really quick and people can get their answers right away. It's not covered yet under insurance.
Yes.
It's like 200 and something bucks to do it. But what is it worth to know that you have osteopenia when you're
Mhm.
45 or 50? We can
Yes.
do so many things. Number
Yes.
one, we can improve their protein intake. We can vitamin D, right? Vitamin D levels.
Yep.
We could talk about vitamin D for an entire
Yes.
episode, right? It's one of the most important
Yes.
hormones in the body. Pulsed electromagnetic frequency. And then the big one is get in the gym or get some
Mhm.
exercise bands. We got to
To
get your
start.
muscles
Yes.
just to start. And then we could talk about infusions and all this. There's so many other things out there, but first you have to fix their D levels and their
Yes.
calcium, all this stuff and their thyroid levels. So no, it's so important. It makes so here's my thing. If something costs even out of pocket 200, and I know not everybody can afford, but
Correct.
or
Yeah.
or get a DEXA scan, which is totally covered by insurance. Why would you not want to know
Hmm.
that
Hmm.
information early? Because I can tell you, for those of you listening, when you get to me and you have 6 fragility fractures
Oh,
in your spine, and your spine is literally, we just call it's just dust. And I can't even, a lot of times we can't even do anything. Sometimes the treatment for some of these patients that are so bad, bed rest. I can't put screws.
oh,
I can't put screws in their spine and
is
fix
there?
it.
Yeah.
Now, there's vertebroplasties and kyphoplasties and things like that. And, the societies it depends on which society you look at, because if you have a vertebroplasty, you're more likely to fracture the next level, above it. Kyphoplasty is a little bit, better. So it goes back and forth in our
Oh,
literature, and
yeah.
our board examiners are kind of, it's interesting how they go back and forth on that particular topic. But the best way not to discuss that
Not,
topic is not have that
not
problem
to
in the
have it.
first place.
Exactly.
So to me, with something low cost, there's nothing that's going to happen to the people. Like it's not like, we're not doing a biopsy on them or opening them up
Yes.
to figure it out. You're just getting you either get the DEXA or you can get now an ultrasound, and that's it. And
Hmm.
and then you can make, like decisions kind of going down the road. Okay, one,
Yes.
we have to cover this topic because it's the hot, I mean, it is the topic, right, of the last
Uh-oh.
2 years. GLP-1s.
Oh, yeah. Yeah.
GLP-1s. So
Yes.
GLP-1s so this is my understanding is this, and you tell me because I want to know for me. So for women that are on GLP-1s, what I worry about when people are on GLP-1s, loss of muscle mass,
Yes.
huge. So there's all kinds of stuff to do on the loss of muscle
Yes.
mass thing. But again, if they're getting it from their hairstylist, then nobody's watching their loss of muscle mass or their loss of the
Co-
muscle mass in their face and all the the stuff.
Correct.
And then obviously the gastric emptying problem, which can be, very severe. I don't care about the nausea and stuff. That comes with it. We have to deal with it
Yes,
however you deal with it.
yes.
But people can get like serious gastric
Gastroparesis,
emptying.
yes,
It's bad.
yes,
And they
yeah,
can't empty and then it's bad. It can be bad. So you have to really watch for that. But my understanding, and I'll let you take it from here, is that in perimenopause or menopause, you're not it's fine for those people even if they're having symptoms. It's not a contraindication, but my understanding is that the results of the weight loss and the preserving of the muscle mass are much better if they're also on hormone replacement
yes,
therapy with the GLP-1s, and that's critical. I'll
yes.
let you take it from here.
Well, so one component that we didn't talk about of one of the symptoms,
Mm.
or not even a symptom, but it's what happens is that we start to lose our lean muscle mass when we enter this perimenopausal menopausal
Mhm.
transition. So
Yes.
we're already losing that.
Yes.
Of course, we didn't talk about the weight gain and that, we
Yes.
kind of
Yep.
have
Yep.
more of that
Yep.
abdominal obesity that we
Mhm.
see happening because our brain is telling us to store more fat. We can get some estrogen from peripheral conversion of fat cells. And so our brain thinks, well, let's store it, like we're a hibernating bear or something, and
That's
keep it
right.
right here in this belly area. So we already see that we're kind of, accumulating more fat in the
Right.
abdominal area. We're losing more muscle. And a GLP-1 is great to come in and, really work in the brain and the digestive tract to kind of slow down the cravings, turn off that hunger signal, but it also, of course, slows gastric emptying and
Yes.
intestinal transit time. So meaning it's going to, slow all of the processes that we have to go through to eliminate waste. And when we talk about, the benefits, as we're losing weight, we're going to tap into muscle. So when we're on
Mhm.
that GLP-1, so we're already losing muscle mass because
Mhm.
we're
Yes.
perimenopausal, menopausal. Now we're taking the GLP-1. You're going to lose even more muscle mass. And so if we're going to start a GLP-1, we need to be with a dietitian nutritionist. We need to have that visit first so that we're discussing what this protein looks like on our plate, what the fiber looks like on our plate, how are we balancing the carbs throughout the day, and what are our activities. It is not enough to be on the treadmill. It's not enough to run a mile or walk a mile. I will have some patients say, well, I do 12,000 steps a day because I work so much. But what are we doing about the muscle? So we have to do
Exactly.
weight and resistance. We
Exactly.
have to do, like, you just don't take the GLP-1 if you aren't committed to doing the work of building the muscle
Love
because you're
it.
going to lose it and you're already losing it anyway. Now, has it been phenomenal in helping the perimenopausal patients lose weight? Absolutely. It has. But then you mentioned, the side effects, especially
Hmm.
gastroparesis, which is
Yes.
when the stomach, is not able to empty. I, knock on wood, have not seen it in any of my patients. But the other issue that I do see is that we get to a weight loss goal and then stop the GLP-1, and then over the course of the next year or so, we gain all the weight back. And so
Yes.
I think it's really important, as I mentioned, to make the commitment that you're going to, we're going to build muscle while we're taking the medicine. We're going to adjust our diet because some patients just want to take it and just let it work without doing any of the other things because you're just not
Right.
eating. And we're really going to notice the muscle wasting in those patients if you're not even changing the diet, you're not changing the protein and fiber intake. So we're going to see, it's going to be obvious that you're,
Yes.
taking a GLP-1. But the
Yes.
other part is that you're making a commitment that this may be a lifelong medicine. This may be a lifelong medicine, even for the patients who have made the lifestyle changes. Even in those patients, now I'm not in their home, so I can't confirm what I'm being told. Are they really going, doing 155 minutes of aerobic and then 3 days a week of resistance
Mm.
training? I don't know. I can't, confirm that. But in those patients that, have gained weight back and are still doing the lifestyle changes, they're committed to those lifestyle changes, but they still end up gaining the weight back. Well, those are the patients that I think really have more of a food noise component to what got them to obesity in the first place, is that there's just that constant thought of food. And that is one of the things that those GLP-1s does. It turns that food noise off. And so if you're going to make a commitment to start, you have to also know that it may be a lifelong medicine. And then if you have one of these unwanted side effects, like your
Yeah.
gastric emptying has stopped, or you've got a bowel obstruction, or you end up, with pancreatitis, those risks are low. I mean, the literature says that, the risk
It's
there is
low.
low. And is it higher in those patients who were taking the medicines for diet, as diabetic patients versus as weight loss patients? We're still waiting on more,
Hmm.
literature about, to really differentiate those two groups. But knowing those risks, but also knowing that if you commit to it, it may be a lifelong medicine because every time you go off of it, then it's a cycle to go back on because you are gaining the weight back. So, I mean,
Yeah, they
it's changing lives. I will definitely say it is in this where
yes.
you're doing all the things to try to get rid of it and nothing else is working. And then you start the GLP-1 and it's like, I mean, it feels like a magic medicine.
I mean, I
Yeah.
think it's, I mean, I've come around when they first came out, I'm always skeptical of anything
Yeah.
where you're hearing it constantly on CNBC, right?
Yeah.
Because then you're like, oh, this is a
Why?
financial thing,
Yes,
right? It's
why?
it's
Yeah.
Eli Lilly and all their
Hmm.
cronies and stuff pushing it. But I've certainly come around and something GLP-1s are something that we use on on like on specific patients. Like I just saw,
Hmm.
and I don't like to start them if they see me at the integrative health clinic right away
Hmm.
because first we work on there's a lot of other things we can do before depending, but like the other
Correct.
day I saw this lady, she's like 300 pounds. I mean her A1C is 13.4. I have no
Oh,
idea. And I just said to her, I gave her the whole, I was like, I don't normally we don't do this, and she had all her labs with her, she had everything, so I was like, you
perfect.
are the perfect candidate because from
Yes.
a metabolic standpoint you are wrecking and she
Yes.
needs a lot of other stuff.
Yes.
That's just one of the things. But what we do for the muscle standpoint is obviously the education on the amount of protein intake,
Hmm.
and then also on getting into the gym or
Yep.
or exercising, however they can do that. And we make recommendations. I'm like, it has to at least be bands, but obviously, if you can get to the gym and actually do real resistance at
Correct.
least 3, 4 times a week, it's great. But then we use another compound. It's called MYOSMD, but it's
Hmm.
forteotropin, which is it's a myostatin blocker, and so it prevents the loss of muscle. And it's just like this protein. It's just the powder, and you put in your protein shake, and it actually needs a
Mm.
prescription. Uh,
Oh,
yeah, yeah. I'll send you the
yeah.
information on it. It's actually really good. We've been using it for quite a while. It's really nice to try to preserve muscle, and they actually have really good. They have some really good data that they've compiled, on that stuff, which is really good. And then we're going back to the peptides. Utilizing some of those like growth hormone stimulating peptides, as long as
Hmm.
they have zero history of cancer. I mean, we just kind of
Mm.
work them up because any of these things, obviously, if you put somebody on something, your growth hormones up and you have cancer, it's a
Yeah.
problem. So they need
Yes.
to really be clean of that stuff. But adding some of those growth hormone stimulating peptides in the evening can make a
Mm.
significant difference on preserving. I had mentioned one before, CJC
Yes. Yeah.
1295, and then ipamorelin, tesamorelin. There's all these other ones, and again, they're not. Again, as physicians, we have to be. This is why people have to go through physicians, because we know exactly how they work, what the
Hmm.
contraindications are, who should be on them and who should not, and we're going to monitor you with labs and make sure there's nothing. We're seeing what your growth hormone. We just kind of we know what's going on. If you just start getting
Well, if you
compound
order it,
pharmacies
exactly.
from wherever, because you could just go online, right, and just get these
Yes.
things. You do it on your own, and you're the
There's the
type of
risk.
people that I'm talking about. You have all kind. You just have risk. So I just always pound the drum. And again, a lot of the stuff. That we do in integrative health, and even, like, to be honest with you, in spine surgery and in orthopedic surgery, and a lot of stuff is not FDA approved. We use things
Correct.
off label,
Off
but
label.
as physicians we can do that. But we have the
Because
the
we,
knowledge and background. We're experts at physiology. We
yes.
understand pharmacology. We
Yes.
understand that we're not just saying it because it's nice, because we're looking at
Correct.
Chat GPT and looking at a list of what it does.
What
That
is,
looks amazing.
yeah, no, no, no,
Oh
no.
my God, I'm going to be on that. Anyway, that's kind of our strategy with the
Mm.
GLP-1s, and I've definitely come around to it. And some of these people really need it. And then the other thing that's kind of cool, and I wasn't on this train before, but again, I'm connected to so many integrative health specialists now across the country, and I always try to pick everybody's brain, like, what are you doing? This microdosing, a lot of people are doing just a lot smaller doses.
Hmm.
They're combining that with these growth hormone stimulating peptides, and they're getting really good results with
Mm.
none of the side effects of the
Wow.
normal doses. Now, again, the
Of course.
example that I gave you, if they come in and their A1C is 13.4, and they're morbidly obese and
Yes,
and,
we're
and di-
going right.
like,
Yeah.
then that's
Yes.
like microdosing ain't good. What are you going to lose, a
No.
half a pound?
No.
No. But if somebody is, because to me, I was seeing it with colleagues and people that I work with in the hospital and stuff. I'm like, people are on GLP-1s. I'm like, you Like, I mean, you're not even close to the way you're
Yes,
like
yes,
way below
yes,
the BMI
yes.
of
Of
any
of
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 any society.
19.
Right. Yeah, exactly.
Yes,
Like they're on because they just want to look, perfect. So
yes,
those people, if they want to do something, again, not medical advice, nothing I say on this podcast is medical advice or that you
correct.
say we're just having a
Yes,
conversation. These are
yes.
all our opinions, but I'm like, for those people, yes, if you want to go to physicians that do this, you can think about like microdosing and thinking about
Mhm.
some of these other peptides, as long as you're really watched very carefully and your labs are taking all that stuff. You can look into those things. But why are you on full doses of like semaglutide or, all
Yes,
and all
terzepatide, yeah.
Mounjaro and whatever, that you name it. And it's funny, the American public knows all the names now. Like
Oh,
they
yes.
Zepbound, Manjaro, they know all
100%.
everything. And then you go, like because the commercials are,
Yes.
bombarding us and stuff like that. But it's really exciting to see, like going back to what we were saying before, how kind of medicine is starting to get into kind of like the pop culture world and that
It is.
society. And it's going to change because people are like, I don't want to feel like this anymore.
Hmm.
No,
Hmm.
just because I'm 50 or 60 that doesn't
Yes.
mean I have to feel terrible.
Correct.
Just because my
Correct.
doctor's like, oh, this is normal. Well, what do you want? You're old. Like when
And it gets it. Yes.
that's not what we're
No,
doing. So I think, I mean, like what you're doing, it's helping so many people. I'd love to have you back on the show
absolutely.
because we didn't even cover things like something that's so common and like even I seeing it more now. It's like polycystic ovarian.
Ovarian
Like
syndrome.
it
Yes.
is so
Yes.
I mean it's big. I mean right up to 13
Hmm.
14% of the population or something like
Yep.
that has it. That's a lot of people,
Yes.
but
Yes.
yet we're
And gets missed just the same way, right? Just the same way as perimenopause.
right.
Oh, well, it's normal for you to kind of have some irregulars. Oh, it's normal.
Yep.
Again, it can be missed.
And they're
Now,
miserable.
yes, yes,
Miserable.
and there are options. That's the
Yes.
thing. There's options. You don't have to
Yes.
be miserable. Like there are options.
You do not
So
have to
yes,
be miserable.
yes,
So on that note, so if people now it's awesome because you are doing this multiple states, you've got this
yes,
online thing, you will coach people through
yes,
everything. Can you tell us about
yes,
what you've developed, your
yes,
project and how they
absolutely.
can reach you? Because I'd love people to, communicate with you and get the help that they need.
Absolutely. So, I'm Your Menopause MD on all social media platforms and YouTube. And then my website is Your Menopause MD. And I have a telehealth platform. I see patients now in 16, soon to be 17 states. We are just adding California. But I offer telehealth visits, 1 hour appointments. We talked
Hmm.
about how you
Yep.
just can't cover
Yep.
everything in a 15-minute visit, right? And so, through my own journey and having been in private practice, recognizing that we just in a private practice, we've got patients double booked, stacked in 10-minute appointments, and a perimenopausal complaint or question is really more of an afterthought where we might just hand you a brochure and say, just read this over and this will give you all the education you need. So my visits are 1 hour. So we are diving into symptoms. We go through education. We go through risk benefits. And then we come up with a customized plan because it is not one size fits all. Every patient is going to have a different plan and may have a different dose. You may have a
Mhm.
different method of how we administer the hormones. It might be transdermal with the patch or with the spray. It may be with the vaginal ring. So we come up with a
Mm.
formulated plan specifically for you, and then we follow up, and those follow-up visits are 30 minutes. So we really kind of dive into, what's improved, what stays the same, what do we need to add? Do we need to treat anything else? Do we need to talk about any of those medicines for hypoactive sexual desire disorder? And we are able to offer lab testing, so we can order labs, even though we're a telehealth platform, we are able to get labs and then have those labs reviewed. So it is an option to be able to have a visit in the comfort of your own home or wherever you are
Mm.
and have 1 hour to pick my brain and then come up with a plan for treatment so that you can feel normal. So the website to schedule is yourmenopausemd.com, and then all of my education on social media, Instagram, Facebook, TikTok and YouTube.
Well, it's great. They can have their own personal podcast with you.
Yeah.
like I did. I don't know if they're going to get the 2 hours that I've had, but they
Yes.
get to have their own personal. And you're absolutely right. And it really, it's like the main problems that people are having about being dissatisfied with their life and the quality of their life and things like that. What we've done in medicine is, we focus on sick care. We focus on all these people
Hmm.
that are really acutely ill. And
Yes.
it work to be honest, it works in the spine surgery thing because people either need spine surgery, they don't. I
Oh,
have
they
to
don't.
send them for some treatment.
Yes.
So, like I don't need to talk to them for 2 hours to discuss. It's like, oh, you have this structural problem. We
Hmm.
have X, Y, and Z, and this is what we're
Yes.
going to do. But I found over my 20 years in practice that people were talking to me much more about how sick they feel than about their
Yes.
spines. Yeah, we talked about that, and
Yes.
then we had nothing else to talk about. I said, okay, yeah, we'll take that disc out. It's a little
Exactly.
minimal surgery. We'll do it at the surgery center. Okay, great. And then they would just start telling me I don't feel good. I'm like,
All the
well, do
other
you have a
things.
doctor? Oh yeah, I've been going to the same place for 10 years. And I'm like, well, your A1C is terrible to the point where we can't even do your surgery until you get
Surgery.
it in control. Your hypertension's out of control because my nurse came in and said this patient might need to go to the emergency room,
Oh,
like that kind of stuff. And it's over and over and their hypertension, their
yes.
autoimmune disorders, they're being just pounded with all these medications that are causing, you know what? It's like, okay, one medicine doesn't work. You go to the next one and they have side effects and
Every
consequences. And you
time.
can't really manage their life and their lifestyles by just seeing them and changing their prescriptions.
Medicine.
So I think what you're
Yes.
doing is really the future. And I think that you picked the right topic because if you're doing, you're a menopause MD, I mean, you should have, like people should be pounding after watching that. They should just be
Yes.
pounding on the door, just saying, I
Yes.
need to talk to this woman right away to figure out why
Hmm.
I feel like this all the
Yes.
time. I don't want to be like this, especially the ones that some of these women, they're like, hey, my kids are out of the house. Is this the rest of my life?
This should
Like
be when we're living our absolute best
100%.
life.
I
Like,
just got my first one just left. My first one just
yes.
left. We got 2 years with the youngest.
Yes.
Um,
But
and
this should
so,
be the bet. Like you've done it. You've gotten them out of the nest. They're out flying on their own. Like this is when you should be
yeah,
enjoying the fruits of all of your labor,
you did
right?
your job, right?
Yes.
Our job is to do the best we can with our children. And then we need to just at some point, like we said before,
Yeah.
you got one shot, one at bat.
Yes. Yes.
Like you don't want to do all that. I mean, and again, I see that with
Oh,
everybody. I always tell the same. It's not like a joke, but I always say, like, when I come to the doctor's lounge now, all the doctors start to scatter because they know I'm going to give them a big lecture about integrative health, but mostly about them.
yeah.
I'm like,
Yeah.
first of all, they're sitting there eating their donut,
This,
their second donut
hmm.
of the day. They look terrible. They have the same, docs have the same issues that everybody else has,
We do.
and in some
We
ways
do.
worse, especially when it comes to mental health.
Yes.
And I'm always telling them, but now, I always ask them, I'm like, you know, is this what you signed up for? Like not feeling well. I mean, I'm like, you just
Mm-mm.
dedicated your entire life to taking
They're
care not
helping
only of your
everybody
family,
else.
but all these people. And
Yep.
now you're sick, and now you're just going to get sicker, and that's it. And
Hmm.
just going to keep coming in and walking around and being miserable and yelling at the schedulers and the nurses and everybody else because you feel terrible.
Yeah.
And so anyway, whatever, they scatter, but eventually, some of them are my patients now. So
A little bit at a time.
I'm
Exactly.
happy that I've converted some of them, so they'll come talk to me. It's actually kind of fun to see them because it's just they never thought that they were going to come to the spine surgeon to get, advice on weight
Exactly.
loss or their mental health or whatever. But I'm like, I love
Hmm.
this stuff. This is
Yeah.
all, I read and it's fascinating. So, on that note, unfortunately, our time has come to an end. This has been amazing. I mean, seriously,
Yes.
this is like, I mean, this is like you just gave us a textbook on perimenopause
Yeah.
and how to treat it
Yes.
and the misconceptions. And I think that the people that did stay through the whole episode are going to be much
Yes.
smarter for it and
Yes.
understand and hopefully this a lot of people get sent your way.
Yes. Well, I appreciate it.
From this, what happens if
Yeah.
you're not in it? So if they're in a state that you're not currently in, is it just somebody you can't treat?
I
You just have
can't.
to tell
Yeah.
them, but that'll be
So,
clear on the
yes.
website, I'm
Yes.
sure.
Yes.
Yeah.
And
Okay.
so they have to
Yeah.
be physically located in one of those states at the time of our visit. at the time of the visit. So, and they're on the website. And so if they want to schedule, you just go to the website, click book an appointment, and it
Okay.
kind of walks you
And they'll
through,
tell
where
you,
you need to be. Yep. Yep.
okay.
It's pretty straightforward.
They could drive 10 miles to their neighbor state
They actually
and still
could.
see you as
They
long.
have to, yes.
It's
Yeah.
interesting. We need to go. I mean, there is a licensing system where you can get like the universal license.
Yes.
I just know one of my friends, the first one who's gotten it,
Yeah,
finally.
the compact.
Yep. Where
Yep.
it's every state. He said it was not that easy to get, but he finally got it. But I think we could have an entire podcast discussion of how our societies and all our other people
Yes.
are just, we get a lot of money grabs too, because licenses should be universal, because I think practicing medicine in Minnesota is the same as California, is the same
Yep.
as Florida. I don't think we have different species that we're treating.
We
They're
don't, but
humans
we
or
still have
humans.
to go through all the hoops to be able to get a
Same
license
thing.
in each one of those separately.
Same thing
Yep.
with the legal, for
Mm-hmm.
lawyers and for all these
Yep.
other specialists. It makes no sense. That stuff has to change. That's for another discussion.
Yes.
So on that note, thank you so much,
Absolutely.
Doc, for coming on the program. It's been great. And thanks everyone for watching another episode of Wellness at the Speed of Light podcast. I hope you've learned as much as I have. And we look forward to having Dr. Anthony back on the show real
Thank
soon.
you so much.
Of course.